Amandla. 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 Amanga. 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 Siyabonga maqabane. Sizoqala ngoku. Sizoqaliseni ngoku. Igama lami ndinguAnele Yawa. I am the General Secretary of Treatment Action Campaign and the Chief Accounting Officer of the Ritshidze project. But before siqale ucomrade leyana ucomrade ungichukumisile wancingisenya ingoma. But I'm not good apha ekuculeni. Ithi le ngoma maqabane. Sekungcono basidubule. Sekungcono basidubule thobola. Sekungcono basebulale thobola. Sekungcono basidubule. Sekungcono basebulale thobola. Ngcono basidubule. Sekungcono basebulale thobola. Sekungcono basidubule. Sekungcono basebulale. Sekungcono basidubule. Sekungcono basebulale. Sekungcono basidubule. Ithi ke ngoku enye before siqale. Sijonge ngane thena. Sijonge ngane thena. Noma kunzima bafazi. Noma kunzima bafazi. Sijonge ngane thena. Sijonge ngane thena. Noma kunzima bafazi. Noma kunzima bafazi. Sijonge ngane thena. Sijonge ngane thena. Noma kunzima bafana. Noma kunzima bafana. Mandla. 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 Qina mntu ophila lenjongo nagawulayo qina. Qina mntu ophila lenjongo nagawulayo qina. Manibonge. Kuthi sonke abakhoyo apha ngaphakathi. Also ngixolise ukuthi siqala 20 past. We were supposed to start at 10, but we had to wait for wonke umuntu abekhona ngaphakathi in order for us to start. Ezibabe sendizintroduce ke igama lami. I think kuyaba ngcono ukuthi nama comrade la lapha as introduce. I'm only using this hand to eat, so ngizawuqala ngapha ndibheke ngapha.
Ngiyabonga GS, mina nguSimphiwe wakaXaba, ngi-project officer ye-Ritshidze. Ngiyabonga.
Sanibonani endlini. Igama uLondiwe wakaKhuzwayo. I'm the KPO, Key Population Organizer for KZN. I'm also from EPWN. Ngiyabonga.
Sanibonani maqabane. Igama lami uWandiswa Mhlongo. I'm a district organizer while at eThekwini South, and I'm also from TAC, Treatment Action Campaign.
Siyabonga. And also phakathi kwethu sinaye usis Promise Sithole or Primrose from the Health Systems Trust. Sibe naye usisi Nomusa Mkhize for the department from the Department of Health. Naye usiso Gasa from the Department of Health who's our joiner online. And also in the room we do have Comrade Eric Motau from UNAIDS South Africa. And online we've got other people, PEPFAR South Africa, CDC, USAID, and some of the district implementing partners, as well as the National Department of Health. They are online. Namhlanje sila eThekwini sizo nikezela ingxelo about umsebenzi esiwenzayo kuma clinics esebenza kuwo apho simonitorisha khona i-services that are meant for people living with HIV, people living with TB, key populations, and umphakathi wonke. With a hope that the report sizayinekezela la is not gonna just be a report and it ends there. The provincial manager of TAC was a KZN. I'm told good he is coming because I requested him that we need to have a meeting with the HOD and the MEC as a matter of urgency. Because we fought as the sector of people living with HIV, Uguti KZN must host 2023 World AIDS Day. If someone is coming to you as politicians and say, as KZN, we are hosting the World AIDS Day, you must know it is because of us. But also, as I'm standing here, you know, last night I received a very disturbing message, which I think we need to discuss it with the Minister of Health and the Deputy President on the 1st of December. Because as people living with HIV and people of South Africa, we were promised up at Durban in June by Minister Joe Pal, a city as the country, a policy has been approved on multi-month dispensing of antiretroviral treatment to people living with HIV who are stable on their treatment. Last night, before I slept, Comrade Moses, Comrade Buto, and all of us, I received a message. The National Department of Health is considering not to implement the multi-month dispensing of antiretroviral due to budget constraints and all what have you. And I want to say it here, colleagues, those online and those who are here, is to say, if what I heard last night is a truth, that is a declaration of war between people living with HIV and our government. If it means that we must disrupt the World AIDS Day in order for our government to implement the multi-month dispensing of antiretroviral to people who are stable on treatment, let it be. If it means that the World AIDS Day in KZN must not take place until we are given the assurance, let it be. So, I want to make it clear here, Guti, we are not here to beg. We are here to demand what is constitutionally ours. And if something is in the policy of government, it therefore means it must be implemented. We cannot accept it, comrades. Mpagat, Uguti, every time when we have a problem within the health department, and when there is no money, people who must suffer are people living with HIV and TB, because that's where always a budget cut takes place. Even now, there was a mid-term budget speech by the Minister of Finance. HIV and TB services are the ones that are suffering. And during the lockdown of COVID, and it was during a lockdown, HIV and TB was no longer a priority. A priority was the COVID. And as the result of that, our government, the Treasury, took more than 300 million from HIV conditional grant by Fagalakwi COVID response. Today, we are being told that there are about 100 facilities in South Africa that are not doing well on the second and the 35 and the third 95 on retention to care and adherence. We are saying to them, we warned you about this as early as 2019 when we started Ritshidze. But because you never wanted to listen to us, this is why now many people living with HIV are disengaging on care. That's why we have a high defaulter rate, because during the time of COVID, we kept on going to clinics, gates were locked, we were taken in tents and all that stuff, and other HIV-related services like your prevention and all what have you were suspended. So what I'm trying to say, from where I am standing, I feel Uguti, at some point we are being failed by our government. And in order for us to improve the quality of HIV and TB services and other services that are meant for key population, we need to stand up, scale like with facility levels, and I am saying this without any fear of contradiction. I'm also serving in the board of the Office of the Health Standards Compliance. I told them to go and tell the minister that I am not begging to sit in that board. If the demands of people living with HIV and the public health care users are not resolved in that board and the minister, why should I sit there? So, without wasting any time, comrades and colleagues, ndiyabona bafikile abaphathi at the district and provincial level, but uSimphiwe is going to write amagama abo so that ndibabize kakuhle on top of abasesiba recognizile. Without wasting any time, so uhlelo lethu the way eluzawuhamba ngakhona sine topics different, from issues of staff and waiting times, ART collection, ART continuity, key population, index testing, infrastructure and clinics conditions, TB infection control, and then after that we will give 2 minutes to organizations of people living with HIV that constitutes Ritshidze, NAPWA, Positive Women's Network, Sanarela, and Treatment Action Campaign. 2 minutes, 2 minutes, 2 minutes. And then after that we will give to each Department of Health, either at a district or at any level that is available. But also, as I've said, from this meeting, we're gonna convene a meeting with the HOD and the MEC. Personally, I am tired of these meetings, because the report that is gonna be presented here is not different from other reports that we presented. And now, personally, what I'm going to start is a campaign of being disobedient, because being obedient at times, it makes people to think that you are a doormat. We are not doormats. We are the citizens of this country. And I am calling upon you, colleagues, 18th and the 19th, get registration. 24th, 2024, we are going to elections. You need to use your power to tell what you want from the politicians. Next year, it will be 30 years since after 1994. And little has changed with regards to our conditions at facility level. In March this year, bekunesiteleka sabonisi nabanye abantu abasebenza within the public health system. Gates of clinics were closed. They were burning tires. We were unable to access healthcare services. And after that, and these people who are working within the public healthcare system, they are not accessing healthcare services within the public healthcare system that they are serving. It's like me cooking food for you, dish for all of you here. When I'm about to eat, I go to Spare and buy kwa Spare. Guess what? The National Department of Health has a shortfall of about 10 billion. And they don't know where they're going to get this money because they have to pay abasebenzi. Abonisa, abobani. The same people who denied us access to healthcare services. I said in Mpumalanga and Gauteng as well as Eastern Cape, next time, when the healthcare worker unions are on strike and they disrupt healthcare services, we must organize taxis and buses and take our people to the nearest private healthcare hospital and occupy them. So that when they close our clinics, we know where they get healthcare services. We go and demand access to healthcare services with private. And if it means we must be arrested, we must be shot and be killed for what we believe in, let it be. So without wasting any time, I am going to hand over to Ukombe, to Simpiwo and the comrades to lead us. But also Simpiwo is going to acknowledge, before she starts, abaphathi department abafikileyo. Over to you, Simpiwo.
Ngiyabonga GS. Siyabonga kakhulu phakathi kwethu sesijoinwe umama uMasondo kanye nomama uMdluli. Siyabonga kakhulu. Sizoqhubeka neprogram yethu. This week we launched the 3rd edition of the State of Health Report for KwaZulu-Natal, developed used data from Ritshidze's community-led monitoring. Ritshidze monitoring takes place on a quarterly basis in 126 facilities across the province. This week we are holding 3 district community meetings. Yesterday it was held in Ritshidze. Today we are here in eThekwini, and tomorrow we will be in Umgungundlovu. We will be deep diving into both the progress and challenges across 3 districts and hear directly from people living with HIV, people who use drugs, sex workers, LGBTQIA plus community members, and other public healthcare users as to the real experience using clinics in each district. Here in eThekwini, we monitor 66 facilities. Data are collected through observations as well as interviews with healthcare users, public healthcare users, and people living with HIV, including key populations. And we also interview healthcare workers, facility managers, and pharmacists. Data in this report were collected between July and August 2023. Interviews took place with 66 facility managers. Observations took place at 66 facilities. Interviews took place with 3,992 public healthcare users. 50% identified as people living with HIV, and 21% identified as young people under 25 years of age. Additional data were collected between July and September 2023 among communities of key populations. Interviews took place with 111 gay, bisexual, and other men who have sex with men, 214 people who use drugs, 157 sex workers, and 107 trans people. The first group of issues are on staffing and waiting times.
So I will be taking you through the staffing and the waiting times. Improving the state of health services provided at our clinics so that all people living with HIV and key populations can access friendly, welcoming, and quality services depends mainly on having enough qualified and committed staff in the first place. This year, only 53% of public healthcare users interviewed reported that there are always enough staff at the facilities. This has worsened slightly since last year, where 59% of people said there was always enough staff. The best performing sites are outlined in this table that is shown in the screen. The worst performing sites are the ones that are outlined in the screen. From the perspective of facility staff, only 18% of facilities monitored reported that there were enough clinic and non-clinical staff to meet demands, up to 11% last year. There is still a long way to go to fill in the human resource gap. 82% of facilities monitored remain with too few staff to meet the demands. Of facilities reporting shortages, 24% of facility managers blamed that there was not being enough open positions on staff shortages, while 31% blamed staff shortages on one or more unfilled vacancies. According to facility managers, the most commonly understaffed cadres were professional nurses, linkage officers, and also enrolled nurses. There were 195 vacancies reported in this reporting period. The highest number of vacancies by cadre are by far professional nurses. 62% of facility managers that we spoke to specifically wanted additional human resources for health support from the PEPFAR district's supporting partner, which is Health Systems Trust. However, PEPFAR funding for critical HR posts has only reduced in the recent years. Average waiting times have also reduced by 12 minutes in the last year in the facilities monitored in eThekwini districts, down from 2 hours 52 minutes. An average of 2 hours 40 minutes waiting in the facility. This is including the time before the facility opens, when people maybe will be lining outside the facility. And waiting times after the facility opens have reduced from 2 hours 38 minutes from last year to an average of 2 hours 25 minutes waiting after the clinic opens this year. 21 facilities had waiting times over 3 hours, as outlined in the table that is shown, which some waiting times are over 4 hours. This means that some public healthcare users still spend hours in the facility. And this is a major source of dissatisfaction for those who experience these long waiting hours. 44% of public healthcare users interviewed in this district think that the waiting times at the facilities are very long. This has improved slightly since last year, where 50% of public healthcare users thought that the waiting time were long. That 84% of public healthcare users blamed long waiting times on staff shortages, and 10% blamed staff not working or working very slowly. While 94% of public healthcare users were aware of a clinic appointment systems, only 6% reports getting both a date and a time, and 90% reported just getting a date without time. This means that people arrive early in a cluster in order to get seen, and clinics are empty by the afternoon. Appointments could be spaced out throughout the day to ease this congestion. Filing systems were observed to be in a good condition in 87% of the sites that were monitored, up to 80% last year. Mostly due to filing rooms being too small to maintain. 39% of public healthcare users blamed long waiting times on messy and disorganized filing systems. Messy and disorganized filing systems increased delays and increased the burden of already overstretched healthcare workers. The average earliest arrival time has worsened slightly from 5:59 a.m., which is just almost 6 in the morning, last year to 5:56 a.m. this year. And some people still begin queuing early in the morning in an attempt to get seen more quickly. 34 facilities monitored still have an average arrival time of before 6 a.m. in the morning, 6 a.m. Of 1,577 people who arrived before the facility opened, 15% of them feeling unsafe or very unsafe while waiting for the facility to open. While a circular was issued in May 2019 by the National Department of Health calling on facilities to open by at least 5 a.m. on weekdays, none of these monitored even opened before 7 a.m. Commonly, facility managers tell us that they are unable to extend opening hours due to insufficient staffing to cover this time. Yet, 13% of public healthcare users do not think that the facility are open long enough, and that 38% think that the extended hours would improve the access of services for people. We are now gonna move to our recorded stories.
Mina ngisebenzisa iklinikhi yaselindelane. Ngangifike emhla ka9 August ngiyidate yokuzolandela ingane umzukulu wami omncane ona 6 months umshanguzo. Kwathi mangifika wathi unesi engene kuyena kufanele ngikhiphe ifile lengane ngoba manje kubonakala sengathi mina nginamanga mangithi ingane ngiyayidlisa umshanguzo. Kathi mina ingane ngizwele kuyilandela babhala ekhadini nayo lomgomo. Wathi ayikho nje lento engishoyo mina ave nginamanga ngomama isigebengu. Babizana baze bahlangana ngami baba babili bekhuluma into yodwa bethi ave nginamanga ngumzali nje onamanga ugogo onamanga. Kathi mina ingane iyawulanda umshanguzo ngase ngiphazame angilenzi iphutha kwathiwa nje ngeke uzuthole lutho ke namhlanje uyozubuye ngakusasa uzothola uzokhipha ifile. Ngahamba ngathulanga lutho ngihambela amahala ngigibelile njalo la ngisuka khona ngeziklinikhi ngamase ngibuya ngakusasa ngahlala eminyango ama-hour nakhona ngilinde ifile. Lafuna ifile kwathiwa ifile amalitholakali. Ingane idla umshanguzo lo wama-ARVs odliwa izingane ngoba yaphuma ithelelekile kuma wayo. Mase ngibuya ngakusasa ke ngizobheka ifile ngahlala ama-hour eminyango ngingasizakali. Ngaze ngahamba ngaye lapha ku-container la ikhishwa khona ngacela kulokhipha amafile ukuthi angikhiphele ifile. Wathi yena ingane izalwa nini ngasho ukuthi ingane izalwe kulonyaka isana 6 months. Wangibhekela ngahlala ngingathola usizo wathi angiyobheka ezantsi. Ngahamba ngayezantsi komunye usisi abathi angiyekele ukuthiwa uSma. Ifile lengane wangalithola usisi wabhekwa ngalithola. Ngaphindela eminyango ngama wathi usisi hayi ifile asitholwe mama hamba uyokwenza iduplicate. Ngize ngibona ukuthi hayi ayikho lento bese ngingena ngaphakathi kumphathi ngiyabuza umphathi weklinikhi ukuthi ubani. Kwathi uhamba eminyangweni othize kumphathi. Kathi mphathi ngade ngifike la izolo ngizocela i-treatment engane angiyitholanga. Namhlanje ngibuyile angisalitholi ifile. Wathi umphathi angihambe ngiye kusisi container ngibhekele. Mase ngifika kusisi ngithe uthe umphathi ucela ungitholela ifile lengane. Untombazana alibheka ifile yalibheka yabuya nalo. Ochaza ukuthi ifile belikhona engafuni ukungibhekela intombazana osebenza emafayileni. Ngase ngiyathola ke ifile ngahlala lapho ngaze ngabuya ngo1 lo ngifike eklinikhi ekseni ngo6 iservice yaselindelana ngendlela abangasiphathi kahle ngakhona. Lapho ngihlela eminyango ngishaya umoya nengane kuyabanda kunomoya ohuza lapha phandle sihleli ama-hour ngendlela benza kancane ngakhona. Kodwa bengihamba nayo ingane isemhlanje sigodola eminyango nengane njengoba ngahlala ama-hour eqile ngafika ekuseni ngo-6 kaze ngaphuma eklinikhi ngo-1:30 emini ngendlela bebenza kancane ngakhona. Mina ngokwami ngifisa ukuthi lapha kumafayela kakhulukazi bawasethe kahle amafayela ahlale obala ngedate umuntu. Mangibuya mhla ka9 balale bewakhiphe engayizolo amafayela abantu bakhiphe mhla 8. If ngibuya mhla 10 bakhiphe abafayela abantu bamhla 10 bakhiphe ngomhla 9 ukwenzela ukuthi masifika sheshe sithola amafayela ngoba into elibazisa kakhulu yile amafayela asuke engatholakali. Hey ngiyafisa ke lapho ukuthi behlisa izinga lokudelela amanesi akasihloniphi singama patient engathi bangake bathola ukuyalwa impela ukuthi siyakudinga nathi ukuhlonishwa nathi siyadinga ukubahlonipha mayizothi nginamanga lokho nje kungehlisa isithunzi mina ngimdala ngakho ukuthi ngingasuka ngiyoqamba amanga eklinikhi ngithi ingane ngiyayithatha emshanguzo ngibe ngingayithatheli.
Sanibona. Noma ngangazisho igama lami. So ngizoba anonymous. Mina ngizokhuluma ngepolyclinic kwaMashu. Ipolyclinic sinenkinga khona yonesi bakhona abakwazi ukukhuluma nama-patient yokuqala le.
I use Umlazi Polyclinic. I use KwaMashu Polyclinic. The problem with the polyclinic, the staff, they cannot talk properly to patients.
So endlini ukuthi uze usabe ngisho nokuthi ukhulume nonesi inkinga yakho because usuke sekuhebeze into eyibhadi mawungena khona. Nokulinda ke isikhathi sakhona ayiyalinda shema. Ulinda ukusizwa. Sike sibe nenkinga yokuthi mesiyolanda because kuba uya e-pharmacy uyolanda imithi yakho. Manginesi athambe e-pharmacy. So ngale ngasuzo e-pharmacy lapha e-pharmacy khona nakhona kukho right. Kunenyova nje enzalo lapho. Ugcina usulinda usothi uyagula ulinda medication yakho ugcina usubona late. Awazi lutho ukuthi kumele wenze njani. Uhlale lapha ya ulinde isikhathi eside kuyima umuntu ekathele kubuza ukuthi ufunani uze ngani. Kuyima ukhipha lelo khadi lelo ukuthi uzolanda medication.
So the issue with the polyclinic, the staff attitude there may cause us at time to not express what we came to do at the clinic. And the main problem is that most of the time we wait for long before our file is found. The filing system is very poor at polyclinic.
Ngayengaba nenkinga ngosiswami waye ngecathi waye kwakunescourage ama-twins. So elilodwa lapho kumele endlini samphuthumisa khona ePoly kuthiwa uma ufika lapha utshela security lakhona lithi une-button olipressa le emergency. Lelo button salipressa isikhathi eside ngilokho ngimemeza lutho nesoqhamukayo. And uneso wangidlula nje wangibuka akekho wangisiza. Shuthi kwamele ngize ngilinde yena loyo osizayo abantu abakhulelwe.
My sister had a miscarriage of twins. And then when we arrived at polyclinic, the security told us that there's a button, that emergency button that you should press. And we pressed the button timely, but no one attended to us. So no one attended to us until she gave birth in the car. And when she finally arrived, she told us that the child had already passed on. I use Umlazi H, Umzomuhle Clinic. I went to the clinic to take bloods, and when I get there, the nurse used a needle that was already used for another patient.
Athi mefa ngimbuza ukuthi ngoba le ndaba ithi sefisebenzile nje indaba for athi akuhlangani nawo umsebenzi wami.
When I asked her that this needle had been already been used, she said it's none of my business, she's doing her jobs and she knows what she's doing.
Hayi waqhubeka wakhipha igazi amabhodlela awu3 lawa athathwayo vele vele. Qeda lapho after a week ngabe ngibona esandleni ngabe ngivula amaqhuqhuva engawaqondi kahle.
So she took the bloods, and then after a week, I started having infection in my arm.
Kusuka lapho ugogo wami wahamba ucomplain babona ukuthi abamnaki sashintsha ekliniki kumanje sebenzisa iThekwini gateway article sengithatha khona imishanguzo yami negogo wami sengithekela necream qeda lamabala lesandla.
So from there on, I've moved from the clinic because my grandmother laid a complaint and she was not attended to. Therefore, we have shipped the clinic, and I'm using Arkekan Gateway Clinic now.
Sanibona. Mina ngihlala ka-H khona la eMlazi ngisebenzisa umzomohle clinic. Inkinga yami ngakuyolandela umama amaphilisi. Njengenjwayele mina ngiyohleze landela umama amaphilisi. Ngafika ngo-8 eClinic.
I use Umlazi Zomohle Clinic. I went there to fetch medication from my mother as usual.
Mangifika ngo-8 eClinic ayi sihlale masihleli kuze kushaye o3 uline lo ukuhamba ukuyolanda amaphilisi.
I arrived at the facility at 8 a.m. until 3 o'clock. Nothing was happening.
Sisalindele kanjalo kuqhamuka unesi omkhulu afike asazisa ukuthi nani niyabona ukuthi uhulumeni akaqashi uyadiliza kunalokho kuzomela kusetshenziswane silinde.
So the nurse came and told us that the government is not employing, they are short-staffed, so they might as well have to wait.
Kuswa lapho silinde kanjalo phela siyola namaphilisi kumele sibekezele. Sithi siyabona isikhathi iclinic ivalwa ngo4 seku4 siyabona nalo nesekade ezos update ukuthi uhulumeni aqashi usiyagoduka uphethe umthwalo ukuthi sishayile.
So we waited there and until 4 o'clock, and then the nurses start leaving.
Siyabona nabanye bagoduka abathi nibuye ngakusasa.
We were told to come back the next day.
Hayi ngizama ukuvuka ngakusasa early ngabo 6. Ngifike early nje ngabo 8 futhi kuzame ukusheshiseka. Mangifika phakathi sengenile room yokuyola namaphilisi unesi aqala ngidilika athi date yakhe bizolo nje.
So I arrived the next day. I tried to wake up early. When I arrived at the clinic, the nurse told me that your date was yesterday.
Angisho nesi angidilika ngisho kuze kuthi angikhali lapho kumele ngibeze ngaphela uma uyayidinga treatment. Swa lapho angineza amaphilisi kwaba kugcina kwami belandela amaphilisi sekuyo omunye manje onesi abahloniphi badele.
So she shouted at me before I got my medication. Finally, I got the medication, but I do not longer go and collect medication from my mother because I did not like the attitude.
Sanibonani. Ninjani? Mina ngiphuma eGoodwins ka-E. So last week bengiyile ngoba ngigula.
I use Goodwin's Clinic.
Ya sangafika khona mhlawumbe ngabo 8 ekseni and then ngahlala. Oke basebenza bona shame ekseni basebenza because bakukhona ababephambili kimi. And then ngabo 11 bathatha lunch bahamba bonke.
So I arrive early at the clinic. Usually in the morning they work, they try to push their work. And but at 11 o'clock they all went for lunch.
Ya mabehamba bonke basasala thina sibaningi namapatient abanye bayaqhubeka basangena. And then ke masebehambe bonke mhlawumbe bathatha 3 hours we lunch.
So they took about 3 hours on lunch.
Masibebuya ke emva kwalokho basuke bengasasebenzi shame. Basuke sebezenzela kancane. So uzuhambe nje ungatholanga usizo.
So after that, when they came back, they work very slowly, and we continue waiting for long. They no longer push their work after taking lunch.
Sanibonani, comrade. Mina ngihlala eLuganda. Ngisebenzisa iclinic yaseLuganda. Iclinic yaseLuganda inenkinga eyodwa. Yokuthi noma ugula, uyafika khona ugule unganakwa. Ngisho noma ungabe ugula siphi isimo. bathi mawuthi uyabuza kakhuluma ukuthi kwenzekalani ukuthi silinde isikhathi esingaka na singalitholi usizo basitshela ukuthi unesi uyedwa.
I use Uganda Clinic. The problem with Uganda Clinic, you wait there for a long time and they don't pay attention to you even when you are sick.
Mangabe ubuza ukuthi yindaba unesi abe yedwa na bathi istaff siyashota. Kwenziwa yini istaff sishode na bathi nathi asazi. Into ebengasiza ngayo nje ukuthi basilekelele ekutheni bafake esinye staff lapho ufika ngo7 kuze kushaye ufa ungatholile usizo lapho uyagula uphinde kuthiwe ubuye ngakusasa. Uma ubuya futhi ngakusasa ubuya ngabo7 kuthiwe hayi kuzoqalwa ngani ufike ngabo7 kungaqalwa ngani kuze kuphinde kushaye umuntu elinye futhi ngakusasa awutholi usizo.
So the problem
ukuthi kufanele uhambe noma awunamali kufanele ucabange ukuthi kufanele uzohambe.
So the problem with Uganda Clinic is that we wait for long because they are very understaffed. There's only one nurse and it takes us long to get help. And you are told to come the next day. And the next day still you don't get help and you are told to come back the next day and you are sick and you want to get help.
Mina bengathanda nje ukuthi eclinic yaseLuganda kwandise abantu abakhipha amaphilisi imithi kanjalo nje.
My plea is that they add staff in the pharmacy so we can get our medication.
Thank you. So we will go to recommendations now. But before we go to recommendations, I need to acknowledge the presence of comrade Thando Xolodogo from USAID and Mama Ubaphiwe Nxumalo Pepfa Laeze. You know, colleagues, I'm sitting here and I'm asking myself, we have produced these reports for KZN, it's a third one. And if you go through these reports, this one and the previous two, the problems are the same. And I'm sitting here asking myself, I wonder what has the management from provincial, district, facility level have done about these problems. We are living in a democratic country that has a constitution. In the constitution, there is what they call Bill of Rights and other sections. But in the main, our constitution talks about human rights and human dignity. And from where I'm seated, I am asking myself, Comrade Thando Xolo, what else must we do in order for the officials from our government to understand that what we go through as the poor black people of South Africa within our health establishment is not on. We are not saying here as a community, all healthcare workers are the same. But there are those rotten ones. What is the department doing? What are the punitive measures that the department is applying to make sure that what is enshrined in Section 27 of the Constitution? Because Section 27 of the Constitution gives us, as people of South Africa, and those who work and live in South Africa, a right to access quality healthcare services. But we do not see that most of the times. And one of the things that is frustrating me, the same nurses who are giving us bad attitude, they are the first ones to go to strike and demand for salary increase. For what? Salary increase to continue ill-treating us. And we are going to be accused, Ukuti, we are angry, we are anti-progress. You know, in 2021, during the time of hard lockdown, in Gauteng, people were not getting quality services. And we took a conscious decision to break the law. We broke the lockdown regulations. We slept outside the office of the premier for 3 nights. Police came, wanted to arrest us. We told them, here we are 1,000. We have broken the law, come and arrest us. And we were accused of being impatient. How can we be patient whilst the people are dying? How can we be patient whilst the dignity of the people is dragged into a mud? How can you be patient when the people are ill-treated in a democratic country? I'm asking myself. You know, I was talking with someone about corruption within the police service. Someone high in government. I asked him, Uguti, in America, all police officers have a body camera. Not only to protect them, but also for the state to be aware when these police officers are doing things that are wrong. And we are coming here to share our frustrations. Somewhere, somehow, one healthcare worker who is privy to this, I'm sure Uti, bahlala be complain njalo. But when they go to the private hospital, the first thing they do, they make an appointment with a phone. And they do not understand us as poor black people. When we wake up 4 a.m., we queue in those clinics. Why? It is because without any fear of contradiction, our government, I feel like they have hired some officials who are lazy. You go to Home Affairs, you go to all government departments. Home Affairs, people are waking up as early as 4 a.m. to go and queue there. You go to SARS, the same thing. You go to the public healthcare establishments, the same problem. Are we a caste nation or what? In South Africa, today we've got about 4-point-something million people who are on antiretroviral treatment. And it must not be like our government was willing to do that. We had to take our government to court. We had to break the law. We had to be arrested. We had to be shot in order for us to make sure that we are saving the lives of the people. Is this the language our government officials understands better? The reason in South Africa there are a lot of service delivery protests is not because of the failures of the politicians per se, but the officials who are failing the politicians. And people end up getting angry. They fight for a clinic. They will go and ban a school. They will go and barricade roads. Because people of South Africa are fed up. But I think at some point, Comrade Simpiwe, Comrade Ndivuo, Mzamo, before the 1st of December, I need all the copies of these reports from the first one to the last one so that we can have a meeting with MEC, not Dr. Shabalala. And I wish Dr. Shabalala and the MEC to invite all district health managers and sub-district health managers so that they can tell us what have they done about things that are listed here. Because it can't be true. I am tired of these meetings. Because in these meetings, all what happens after a meeting finishes, I end up being traumatized and frustrated of hearing the frustrations of the community, also reading this, and I'm asking myself, which God we believe in? Are we believing in living God or the other God that I do not know? So, it frustrates me. Welcome, Mzam. I want you as the provincial manager of TAC, Comrade, to secure a meeting with Dr. Shabalala soon. We cannot go on like this, Mzam. If it means, Comrade Tandu Polo and Pepfa, that we must stop this arrangement, let it be. We cannot be sitting comfortable on the expense of the poor and toiling masses of our country. Sit in fancy offices. We are not here for that. We are not here to make friends. Where if friendship does not work, let's stop it. Where it works, let's strengthen the friendship and working relations to make sure that we're saving lives. We are not here to rub shoulders. We are here to work hard to make sure that what is in the Constitution for people of our country is guaranteed and realized. Now I think the time has come for us to use our anger. That is the only language our government will understand. If it means we must, as public healthcare users, people living with HIV, we must organize and mobilize and make South Africa ungovernable, we must not be blamed. It is because we are tired. I am tired of these meetings. I am really tired. I think now we need to prepare our jeans, our sneakers, in order for us to be able to take it to the streets. If it means we must go and occupy union buildings, if it means we must go and occupy each and every legislature in the province, if it means we must go and occupy each and every office of the MEC, district health managers, let it be. We want answers. I cannot accept this. If we are unable to do that, I am more than 100% to step down and we elect another leader who will have the energy to listen to all of these sad stories. I don't have that time. I don't have that energy. So the recommendations, colleagues, are as follows. They are as follows. The KwaZulu-Natal Department of Health should produce an annual report on the number of healthcare workers per cadre employed in each district, include the numbers of people and size of areas covered by these healthcare workers. Year-on-year comparison from at least 2021. The vacancies and the cost of these posts to the government. Fill all vacancies in 2023-2024 financial year. Department of Health should extend facility opening times as per the 2019 National Department of Health Circular. Utilize appointment days and times to ease congestions. Ensure filing systems are maintained in an organized manner to reduce lost files. Open clinic grounds by 5 a.m. so that people can wait safely in the morning. Ensure files are not required for facility pickup points. People living with HIV go directly to the pickup point to collect their ARV refill. Get more people living with HIV into external pickup points to reduce congestion. PEPFAR should support in filling all vacancies at PEPFAR Operation Putuma support facilities in the short term. Provide additional staff for all PEPFAR supported sites to extend opening hours to 5 a.m. to 7 p.m. on weekdays. Fund adequate numbers of adherence club facilitators to allow for the restart of adherence clubs. Health Systems Trust should immediately do an assessment at all PEPFAR Operation Putuma support sites with waiting time over 3 hours and develop a specific plan for each facility that will bring the waiting time below 2 hours. Support the facility to organize and maintain an organized filing system. Ensure files are not required for facility pickup points. People living with HIV to go directly to the pickup point to collect their ART refill. Get more people living with HIV into external pickup points to reduce congestion. Thank you.
The next group of issues are on ARV collection. The revised 2023 National Adherence Guidelines note that time constraints are a challenge to many people living with HIV. They go on to say that efforts should be made to support people living with HIV with suppressed viral loads to receive extended ARV refills and or be enrolled in a repeat prescription collection strategy. Implementing this is vital to supporting improved long-term adherence. Ritshidze data reveals 59% of people living with HIV interviewed reported getting from 3 to 6 month ARV treatment refills this year in eThekwini. This is a small improvement compared to 53% getting a 3 to 6 month refill last year. And it is well below 71% in Mpumalanga which is the best performing province monitored by Ritshidze, and far below the 80% of people living with HIV in 21 other PEPFAR supported countries, reported to get a 3 to 6 month ARV treatment refill in 2021. Of people living with HIV interviewed by Ritshidze, 22% collected at standard medicine dispensing, with 33% collecting at a facility pickup point and 44% using an external pickup point. Of people interviewed, 16% more are using pickup points compared to last year. For those using standard medicine dispensing, 29% said they have not yet been offered the option to use a pickup point. All stable people living with HIV should be offered a range of repeat prescription collection strategy options as per the National Adherence Guidelines. Further, 31% of all people living with HIV interviewed said that they would like to collect their ARVs closer to their home if it were possible. There needs to be enough pickup points to decant people into, especially linked to peri-urban and rural clinics. A diversity of external pickup points providers is needed beyond private pharmacy networks, largely only available in urban areas. To service rural areas, small community-based organizations and early childhood development centers should be considered. In terms of adherence clubs, these options have been devastated since the onset of COVID-19. Importantly, in order to be effective, repeat prescription collection strategies should make ARV collection quicker, easier, and more satisfactory for people living with HIV. Yet this is too often not happening. 56% of facilities monitored said that people using facility pickup points must collect files, take vitals, and see a clinician before getting their parcel. And 84% of people living with HIV said this is the case, adding to delays at the facility. Only 61% say it takes less than 30 minutes to collect your parcel and go, as required in national ARV treatment guidelines. Once enrolled, every effort should be made to keep people continually active. Reassessment should take place at each clinical consultation to understand if people living with HIV are satisfied using their pickup points or club, as positively most people are currently. People living with HIV who are not satisfied or very unsatisfied should be offered a different option that better meets their needs. We now move to recorded stories.
Ngihlala kaji treatment ngilanda ka age mhlawumbe like ake ngithi nje udlulwe i-date bazogcina ngawo okay kodwa ke okwenzekile ngoMay mangaphosisi ngangiyolanda amaphilisi kwakuMay 9 ngiyafika ngangayithola ifile amagazi ami ngiwathatha July mangifika futhi ngoJuly still ifile lami ayalithola kwangiphatha kabi ke lokho ngoba ishintsho lapha ekliniki ka-H ukuthi uma kuzolandwa like ama-dates uma kuzolanda abamhla kanje oba namhlanje umhla 18 abazolanda mhla 18 ama-files abo akhishwe ngayizolo.
We now move to our community members who have joined us in person today.
Sambana comrade. Yo, or ikamonvel. Ngizokhuluma nje mhlambe ngokuqala ukubonga khona indlela asebenza ngama-clinic in terms of collecting manje ngokwasondeza kubantu.
I would like to acknowledge the work that is done by the clinic when it comes to collecting ARVs.
Ngalokho siyabona umehluko, it's fine. Siyajabula ngoba ni vele abantu abaningi bebe-spend isikhathi esiningi ema-clinic. Nokuthola ke mhlambe amathuba la khona nesebekathola sebekhathele. Sebenqena nokuthi bakhiphe the right like i-medicine kubona.
We like to acknowledge that, and we can see the difference that nurses were spending most of the time taking out medications.
Yeah, enye into ebeyikade igcinisa results lapho ukuthi bagcine sebebanika noma yini engayidingi mhlambe patient. Let's say mhlambe i-patient izo-collect ama-ARVs. Ithole mhlambe isinenkinga yokuthi ayisawatholi mhlambe lawo emkhuhlane mhlambe nawo obumzise clinic.
Due to burnout, at times patients were given wrong medication. For example, if you came to collect your ARVs and you have a flu, you end up not getting treatment for the flu.
So kulokho sithi abazame mhlambe ukuthi bas-improvele kuyona indlela yokuthi ba-check ukuthi ama-nurses enza the right thing. Maye omunye uke washo mayelana nani nesikhathi sokwelantshini ukuthi isona mhlambe abavele bahambe ngaso sonke babuye sebengasenzi into right kuyona esicela bas-improvele khona.
We would ask that it improve that way nurses are giving out medication and check that they are doing the work appropriately as they are required to do. As the one said that nurses all go at a break at once. Can they check out on that and see how it can be worked on?
Yeah, into ezothi ingithinte kakhulu le yokucollecta ama-medicine ukuthi kwenzeka nami ngaba nengane okwaba yiphutha yagcina ingasabona emehlweni through ukuthi le medicine ayithola yaba wrong.
What touches me when it comes to collection of medication is that I had a child who became blind due to collecting and being given wrong medication.
Yeah, so lapho kwaba yiphutha khona lenzeka nje esikhatsini esiningi ngoba yayibuya esibhedlela. So ngithe ngifake kwama-clinic ngobani nayo yayi include ama-clinic ngobani sa-refer ukubona sisuke esibhedlela after ethola leyo treatment.
So this happened at the hospital, but I would like to include the clinic because after being at the hospital, you are referred back to the clinic.
So lokho ke kwenzeka kwaze wagcina ekutheni umntana makaboni wagcina ke esehamba nange-wheelchair. At the same time ke isibhedlela leso esagcina si-involve ekutheni sinike ingane leyo wrong treatment kwayisibhedlela esikhulu saseMagandi.
So due to the wrong treatment my child was given, she became blind and she is now using a wheelchair. She cannot walk by herself. And the hospital that we were using is Magandi Hospital.
Ngizocela ungayi kakhulu mhlambe kokuningi kodwa ke ngizocela nje mayelana ne-treatment enikwa ama-patient ey'bhedlela kube khona ukuqikelela okukhulu ngoba manje kuyona yonke into eyenzalayo kugcina sizivela ama-frustrations kuthina as abazali sixabane nonesi mhlambe sometimes singekho mhlambe isidingo sokuthi kuze kufikwe lapho. So bengizocela mhlambe bazame ukubukisisa kuyona yonke leyo nto leyo including ama-clinic noma besirefer ema-clinic abazama ukuthi mhlambe bathole ukuthi leyo muthi loyo kuthiwa siye kuwona lapho kuleyo clinic ukhona ngempela kuleyo clinic.
I would plead that when we are referred to get medication that we are given the right medication. Can that be seen to that we are given the right medication, as things might not result to what I've experienced, that my child has lost sight and cannot walk due to wrong medication. Can they please make sure that does not happen?
Sekuvala ngicela ukuthi ngisho ukuthi leyo treatment eyenzeka ya result ekutheni abazali nasekuhlaleni phakathi abazali zabazali bengane kwaletha i-impact enkulu ukuthi igcine engasahlali kahle nomndeni futhi ngezinye indlela ugcina ungasa-understandelani ukuthi kwenzakalani.
So due to that, my child getting the wrong medication, it caused division between the family, and it couldn't work due to the relationship that we're having with the family because no one could understand what really happened because we're not getting the correct answers in the hospital, but we knew that the child was given the wrong medication.
Okay, siyabonga kakhulu.
Sanibonani. Ngicela ukuba anonymous ngiswakadinga amasho ngisebenzisa clinic.
I use Goodwin Clinic.
Chronic. So ngiyathola kahle medication. Yes, basinikeza.
I'm chronic and I get my medication accordingly.
So indlela eyinkinga ukuthi abakwazi ukuphatha igoli.
The problem is they cannot work properly with patients.
Lendlela ke kusuke kusetshenzwa ngayo ngalolu suku. Usuke ungazi ukuthi umphathi ophethe organizile ukuthi namhlanje sizosebenza kanjani or else nje kuyasetshenzwa nje like ekutheni aqalwe umphathi ekseni abanike ama instruction ukuthi okay namhlanje kuzoba kanje ukuze sikwazi ukuavoida indaba yokuthi sigcina sesihlale usuku lonke sithola usizo late.
So the way the work is being handled, we would like to know that does the facility manager speak to the staff on the work and the duties that are supposed to be performed that day, because if that is done, it would not cause the delay that we experience in the facilities, end up waiting a long time to get service.
Yes. And the other thing, nalokhu kokuthi mabebona ukuthi ay baya complain manje ama patient la esibhedlela sekunento okuthanda kuba umsindanywana. So umphathi akakwazi ukuthi angabi khona ungamboni qobo kodwa at the same time ekhona umuntu in charge for clinic.
So when there's noise, patients start complaining of the service that they are receiving at the clinic. We would like to see the presence of the facility manager within the facility, because she or he is supposed to take action at their present time.
And the other thing enye into nokuthi mawuthi uyacomplain kuthiwe ene hayi ilo hulumeni wenu enamvodelayo.
So, and when you complain and we are told this is our government that we voted for, it's not right.
Yes. Nanti ipeni lapha phezulu nali iphepha. Thatha ubhale phumethini.
So,
Bakhona abaphathi abazobheka inkinga zenu enibhalile lapha.
so we were told there's a pen, there's a paper, there's a complaint box. You write your issues and you place them there, and do not to speak to us. There are people who handle issues that we are experiencing.
Okugcina sengivala nalento yokuthi ene mawugula usuke ugula hayi ukuthi awuphilile la ekhanda lakho usuke ugula. So masilaphana hayi ngoba sisuke sihlanya ukuthi asiphilile emakhanda.
So another thing, when you are sick, it does not mean that you are mentally challenged or you don't think properly or you can use do not use your brain.
So sidinga ukuthi noma ngibuza umchazele kahle nami ngibe right ngoba vele egcineni nami njengoba ngilana ngizosiza wena nawe futhi uzosiza mina ukuthi ngibe khona kule ndawo. So siyathanda ukuthi ngempela inhlonipho ibe khona nomsebenzi wakho ke asazi noma ke kufanele bashintshe staff in government akathathe esinye kwenye indawo sibuyise athathe esinye ngoba naloko okuhlala endaweni eyodwa iminyaka usungenandaba nomsebenzi wakho ugcina vele ungasenandaba nabantu abahlengayo.
So the problem is that we would like that they acknowledge that we are in the facilities and they are working because we are there. Without us being at the facility, they wouldn't have a job to do. And another thing that we would ask is that if the staff can be moved around and not sit around the same facility time over and over again for years, because they get comfortable and feel that this is their space, so they are going to control how it's going to work.
Awukwazi ukuthi if ngisiguli wena umhlengikazi ungibalele ukuzene makushaya upast 2 or 3 ungayi ukuthatha amagazi laphana angiyani sakunika medication yakho akuyone yakhe eka government akusiyone yakhe yena ukuthi kufuneka eze anginike uthando ngiphile ngiphume ngi-right. Thank you so much.
So it cannot be that as a patient I'm told by the staff nurse that if it's about 2:30 p.m. and your bloods are not taken, you cannot come back, I'm not going to be able to help you. The clinic is not for them. It's a government clinic. It's our clinic. We have the right to use them the right way. Mike. I used to take my pills at Tembalabandi W Clinic. Everything was going well until the Tembalabandi Clinic closed down and I was transferred to Umlazi H Mzomuhle Clinic. So I asked if you come with the transfer, what happens? They referred me to the receptions. So when I arrived at the reception, I gave them my transfer letter, and the nurse shouted at me to ask me that I should go back to where I'm coming from and ask them to write properly the medication that I was using and disclose it that which medication I'm using in front of all the patients. So I end up defaulting because I couldn't get my medication. So I then went back and then I asked them for a letter. They gave me a letter and then I never went back to Umzomuhle Clinic. I went to Umlazi K Clinic that I'm using now and I'm happy with the service there.
Thank you. We're going to recommendations. 3 things. The reports that we are producing are not actually designed to find faults or mistakes. They are designed to ensure that we work together with the government to improve the quality of services for HIV, TB, as well as other health-related matters. But the problem in this arrangement, Nondab, we've got a signed MOU with the National Department of Health and in provinces. So on our side, we produce these reports and we hand over copies before these meetings to the authorities with an expectation of when authorities get our reports, they will read them, familiarize themselves with what is on the reports. And then on their side, they will start taking some actions in terms of turning around the situation. But the unfortunate part, the department is not coming back to us in a written form and say, based on this complaint, this we have done 1, 2, 3, 4, so that we can be able to include those in these reports to say, as much as there are these problems, but there is improvement based on this report that we received from the department. And if that is happening like that, it will therefore mean these reports will only be one-sided from what we know as the sector of people living with HIV together with communities. But to what is happening behind closed doors, we are not privy to that information. It will be good as we're moving along to make sure that when the department makes some interventions, that is communicated to us so that we can be able to include them here. 2, colleagues, comrades and friends, we have a problem in South Africa. If you look, firstly, the first problem that we have, we have one state, one government, with 10 departments of health. We've got one national and 9 provincial department of health, which kind of takes lot of the money from the health budget. The health budget is more than 3 billion, or more than that. I'm not 100, but it's more than billions. 300 billion mean to say. But what you see is that huge chunk of the health budget does not go to purchase goods and services. You know where it goes? It goes to pay medical legal claims like your case. Billions and billions of rands are paid by the department to legal firms due to medical negligence. Medical negligence, which is caused at times by negligence. Sometimes it's intentional, sometimes it's not intentional, but in the main, shortage of human resource for health makes our healthcare workers to be overburdened, to be overworked, and as such, they end up committing these mistakes. In Eastern Cape, they just dismissed the HOD, Dr. Roland Wagner. And many people who defended Dr. Roland Wagner as the HOD of Eastern Cape were arguing, saying she managed to cut about 3 billion with medical legal claims. So that is an improvement. And as TAC, we were clear that we are not going to support mediocre. Because in the first place, our government was not supposed to be paying these billions and billions of rands. Because if we are to count the billions of rands which each province is paying annually for these medical legal claims, we can be able to hire more staff members, fix our clinics, buy ambulances, make sure that medical equipment and other things that are needed in our health establishments is there. But our government is unable to do that because the money which is supposed to do that is the one that is paid to lawyers. This is a problem that our government needs to fix. Because if, as the country, we can reduce cases of medical negligence, it therefore means we can have more money to provide services. And here I am. There is the Office of the Health Standards Compliance. There is the Office of the Health Ombudsman. If you are to sit down, colleagues, I'm privy because I sit in those meetings and look at the complaints that are being attended. Thousands and thousands of complaints. Except this, if we were to go to our partner organizations, which are law firms, and say each and every person who got ill-treated, like you, my brother, and say, go and lay complaint and then take this matter to court, our government will be bankrupt. And I'm asking myself, instead of our government spending a lot of money, there is no way that we can work together in fixing the broken public healthcare system. But also I think we have a responsibility as Ritshidze, the sector of people living with HIV, umphakathi, to convene meetings with COSATU, with SAFTU, with NEHAWU, with DENOSA, so that we can reason with leaders of these trade unions as to say, you keep on defending your members, but this is what your members are doing to umphakathi. What are you doing about that? Because I can belong to any healthcare worker union. I belong there alone. But my family members are not part of that. So, the ill treatment that I am giving to my neighbor, my colleague is also doing the same to my family members. And we cannot allow that to happen. But I think we need to work together. Lastly, it is around the filing system. It cannot be true that when I go to the facility, I either go there carrying my ID or whatever, then when I get there, I get my file. And when I leave, I walk out of the facility with a container of my medication and I leave the file behind. When I go on the second appointment, I'm told that my file is missing. Whose fault is that? It cannot be my fault. If you have misplaced my file or you have stolen it, it cannot be my problem. I cannot be the one who is punished, who is not given a medication because of your own failures. Our government told us about tier.net. So, if the tier.net is working, how does it become my fault when my file is missing and you do not have information about the medication that I take? But also, we know as the community that these files are not just getting missing because of inadequate systems of the department. They are getting stolen. They steal them and sell them to other people in order for them to apply for the government grant. What is the government doing about that? Because when my file is missing, it therefore means my medical record is missing as well. And it is given to someone to get a grant fraudulently from the government. What is it that as the department that we are doing to stop this? Because if we do not put systems in place, it therefore means we are culprits or accomplices to this crime which is taking place until we put systems in place. You know, when you go to a bank, you know Uguti, you can access your money to any ATM in the country. You don't have to be asked, Uguti, where is the transfer letter from this bank to this bank? And when you go to our health establishments, if you move from point A to point B, you are going to be asked about the transfer letter, as if the people who are managing the health system are coming from another planet. Hey, man. In South Africa, we've got high levels of unemployment and poverty. And as the result of that, people are moving from point A to point B looking for greener pastures. Do you think if I get a call from my uncle who is in Joburg now and say you must be here before Friday because there is a job, I will think of going to the clinic and ask for a transfer letter? No. What I'm thinking about is a job. And then the rest, when I get that side, I will see that side. But to our surprise, when you go to this nearest clinic where you have relocated, the first thing they ask you is a transfer letter. And if you don't have it, they deny you services. They tell you, go back to KZN to get a piece of paper, a letter. Is that fair? So, if we, as the people of South Africa, who fought for this freedom, who suffered for this freedom, we are unable to stand up and fight against the system, they will continue doing these things. We must be able, as the community, to stand up, speak truth to power, speak out, tell those who are in authority, those who are behind the system, to say some of the things that they are doing to us are not accepted, and we cannot accept them. So we're going to recommendations. The Department of Health should implement extended ARV refills at all facilities from 3 months by end of February 2024 and 6 months by end of September 2024. The Department of Health and Health Systems Trust should ensure all people living with HIV are offered a range of repeat prescription collection strategy options, and those enrolled in pickup points or clubs are active. Ensure that a reassessment of pickup point option takes place at each clinical consultation to ensure people living with HIV remain satisfied with their pickup point or club. Ensure all facilities implement the 2023 adherence guidelines, standard operating procedures with fidelity, including ensuring facility pickup points are a one-stop, very quick ART collection, only visits in under 30 minutes. No need to go to the registry, collect folders, see clinicians, and etc. Ensuring re-establishment, implementation of quality adherence clubs, including group facilitation component. Increasing the number and type of external pickup points to ensure urban, peri-urban, and rural clinics have external pickup points. Ensuring people going back to clinic for their pickup point rescript received the rescript on the same day if clinically well, to ensure no unnecessary additional facility visits with effective recall system to action any abnormal result or alleviated viral load. PEPFAR should monitor and hold accountable PEPFAR district support partners to implement 2023 adherence guideline standard operating procedure with fidelity.
The next group of issues are on art continuity. People living with HIV lead complicated lives and may well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps ensure long-term adherence. But often, when people living with HIV and key populations return to the clinic, they are treated badly, leading to people disengaging from care. A differentiated service approach is required for people living with HIV who re-engage in care. Some will require intensive clinical management, including advanced HIV screening and management. Some will require psychosocial support in the form of quality counseling and group support options. The majority needed to be made easier to collect treatment. These people should be offered multi-month dispensing and should be assessed and offered access to pickup points or adherence clubs as quickly as possible. Implementing 2023 re-engagement clinical and adherence guidelines are vital to supporting improved long-term adherence and retention. Health Systems Trust should support the remaining 24% of facilities and all others in the district in training or mentoring on the changes in the new 2023 adherence standard operating procedures. Ritshidze data reveals that out of 3,980 respondents, 84% of people thought that the staff were always friendly and professional. This graph shows data across time since data collection began in the district. The district should continue to improve to ensure all people living with HIV, key populations, and other public healthcare users are treated with dignity, respect, and compassion at all times. It is also important to note that because Ritshidze interviews take place at the facility, people who have already disengaged from care due to poor staff attitudes, some of who we have heard from today in our community stories, would not be at the facility to interview. The best performing sites are outlined in the table above. And the worst performing sites also outlined. Out of 216 people living with HIV who had missed appointments, 56% said that staff were welcoming when they came back to collect ARVs if they had previously missed a visit, and 52% said that staff counseled them on adherence. 6% said that staff still send you to the back of the queue the next time you come in. Yet, according to the National Art Guidelines and Differentiated Model of Care Standard Operating Procedures, people should not be sent to the back of the queue or made to wait until the end of the day to be seen. A returning patient should take up the next queue space. The guidelines specifically state that no punitive actions are allowed. People should join the queue as normal on arrival at the facility, irrespective of whether on time or late for their appointment. Punitive actions lead to people deciding not to come back again. We need to normalize late and missed appointments without penalty. People who have come back despite being late have made it easier for the health system. It is not necessary to track and trace them and encourage them back into care. The person who has stepped back into the facility so that their experience should be as supportive as possible. While most people did not report transfer letters being a challenge, 94 people interviewed by Ritshidze had been denied access to services for not having a transfer letter across 22 facilities over the past year. While this is a low proportion of all public healthcare users interviewed in the district, given that most people interviewed are unlikely to have attempted to transfer services, it continues to point to a larger problem regarding the communication and policies regarding transfer letters. A reminder that transfer letters are not required in the guiding principles of the re-engagement SOP, which states, if a patient comes from a different facility, it is critical that the patient be provided with treatment on day of presentation. While referral letters are helpful, a patient cannot be required to leave the facility without treatment. 136 people interviewed by Ritshidze had been denied access to services for not having an identity document across 27 facilities over the past year. All sites should be urgently investigated. Again, it is important to note that Ritshidze interviews take place at the facility. Therefore, people who have already disengaged from care due to challenges accessing a transfer letter or not having an identity document would not be at the facility at the time of the interview. Psychosocial support is another critical element to ensure long-term retention. Ritshidze data shows that 90% of people living with HIV interviewed know that psychosocial support is available. However, a full package of psychosocial services are not yet available at every facility. A full package of services should include provision of individualized, quality-assured counseling to patients, peer-led patient navigators acting as a bridge between clinicians and patients, mapped networks or referral services, optional support groups, and food parcels. As part of psychosocial support, support groups should be linked to each public health facility that are critical to provide counseling and support services to people prior to testing, post-testing, pre-treatment, and those struggling on treatment or re-engaging in care after a treatment interruption. Treatment literacy also improves art continuity as people understand the importance of starting and remaining on treatment effectively. Positively, eThekwini performed well on these indicators. Of the 1,947 people living with HIV surveyed, 96% had received a viral load test in the last year, and 96% of those people reported that they knew their viral load. Positively, 95% knew that having an undetectable viral load means the treatment is working well, and 91% knew that having an undetectable viral load means a person cannot transmit HIV. We commend the district on their performance around treatment literacy and look forward to all people living with HIV understanding these messages. 39 facilities had perfect scores where all people living with HIV understand why an undetectable viral load is good for their health. However, other facilities performed much worse as outlined. "35 facilities had perfect scores where all PLHIV understand why an undetectable viral load is good for ensuring you cannot transmit HIV. However, again, the other facilities performed much worse as shown in that table. We will now proceed to recorded community stories.
Ngihlala Richmond Farm. Iklinikhi engiyisebenzisayo ilindelana. Okuthe lapho ngifika ekseni ngafika ngahlala evrandi kulayini. Uma ngihleli kwaze wafika isikhathi sokuthi ngikwazi ukuthi ngithole ifayila lami ngingene ngaphakathi enesini. Inesi indlela ngangilande ama-ARVs wami. Kuthe lapho ngitholana nenesi ke lifanele lingisize inkinga esibhekane nayo ibe enkulu kakhulu ingxabano phakathi kwami nalo ngoba ngathi mangingena wangitshela ukuthi ngihlale angitshela ukuthi ene ifayila lami selivalile yena ngoba mina sekunonyaka ngingezi ukuzolanda imishanguzo kodwa kangade ngile ngenyanga ephelileyo ngafike mase kubhekwa ekhadini leli limhlophe kuthola ukuthi mina ngiride ngama date kodwa yini ifayila lami ulivalile kuthe kusuka lapho waphinde kwabhekwa kwalandelelwa kwathola sekunelinye ifayela elilama lelidala manje mangibuza ukuthi kwenza ulivala kanjani ifayela kungelami engakhulumile nami wangitshela ukuthi akusindaba yakhe le yakuhlangana vele mina nalelo fayela leyo futhi akahlangane nalokho okusukela lapho lento yangiphatha kabuhlungu kangangoba ngihleli mina kumanje 3 months uphelile angidli ama-ARVs ami umzimba wami sewuze uthanda ukuba nenkinga ngiyazizwa ukuthi angikho right angikho futhi kephi ngendlela kwenza ngayo ngazibonela ukuthi kusho ukuthi la elindelana clinic yingakho ama defaulter engapheli yile ndlela abaphatha ngayo abantu ngoba babaphathisa ukuthi ngathi amabhuna kudala nje ayitreat abantu ngalendlela.
Mina ngisebenzisa i-treatment wa ARV bekunenkinga yokuthi mangabe siyolanda amaphilisi like uzothi uyafika mhlambe kuyamenyezwa kuthiwa bazolanda amaphilisi fanele uphakamise izandla yabo okay then angiphasikanga kahle ngalokho because kunabantu engathanda ukuthi bazi ngestatus sami yabo so I decided ukuthi ngishintshe iclinic ngisebenzise iclinic lawa N ngizoqala la ka H bakunika amaphilisi wa 3 months like mina ngowalanda kwiphele box ne bese idate yami namhlanje bese mina ngikhona ukuya khona namhlanje kusasa noma ngabe kuthiwa ngifike ngo6 eclinic but mina ngizo-attendwa ekugcineni awuyi ngisho kulayini if uzoya kuphela box nje awubamba ulayini inkinga iqala mangabe uzokweqiwa idate so kusafanele uwalande ngaphakathi because idate elandela kuseseko yabanye.
Ekwa HM Zomuhle clinic nokungaphatheki kahle khona ngangangokuba ngoba ngangikade ngifuna ukuthi ayo check ayokwazi ngestatus sakhe babuza ukuthi niyahambisana or mhlambe bachaza ukuthi abuye then ezokwazi uzobheka i-certificate yakhe ezokwazi ukuthi athole treatment athole usizo cause ngase ngiyibona impilo yakuhlala kancane abe nomkhuhlane abantu bayazi umuntu wesilisa kunzima ukuthi ayisukela ayihambela eclinic noma ngabe uyazi kodwa ukuthi aze afinyelele ekudleni treatment kuyaye kube wena wesifazane usukume ume ngeenyawo kwaze ngaze ngafise ngathi ngakungcono ukuthi ema chemist kuyakwazi ukuthi athengwe amaphilisi engcono sizithengele ngoba lento yokuhlekwa ngani noma kusuke kuhlekwa isifo naso noma kusuke kuhlekwani
mina into engangiphathanga kahle ngisebenzisa iSavannah clinic la suka la ngiyekhona ngafika ngiyolanda i-treatment so mawulanda i-treatment iphuma kwiphela box for that day ayiphumanga kwathiwa ngehlele ngezansi mangehlela ngezansi abesethi lo kufanele nginike treatment angihambe ngothatha amagazi bese ngithi no amagazi ngiwathatha maku October ngithathe amagazi ami vele athi naye akukho right la kufanele uphinde uyothatha amanye ngithatha ama-ARVs yes so ngihambe-ke ngiyelapha bese nginokha nginese besethi uthini ngithi mina kuthiwa ngize la kuwena athi uzothini ngithi no uthe unesa ngize kuwena ngizothatha amagazi athi ngiqedile ngamagazi I think past 8 nginithathe lapha phezulu ngathi ozothatha amagazi akangilandela so angisayingeni indaba yakho ngithi mina yangazi kodwa kuthiwa ngize kuwena saba ngaleyo nto ke wavele waphuma la eroomini weza kumina washo nje public wathi kushuthi nje bakuthiwa thatha amagazi nje igciwane amaphilisi awadli kahle igciwane lakho kushuthi liphezulu ngeke kuthiwe phinde uzothatha amagazi amaphilisi wadla kahle into yangiphatha kabi yodwa bonke laba abantu ababelapha eclinic basebebuka into upositive lona engculazi hayi wangena nami wangenza esengiphoxile lokho nje wangiphatha kabi angisho ukuthi ngiyamind ukuthi ngipositive ngiyasazi isimo sami kodwa wonke umuntu olapho usebuka ukuthi lo sisi positive akayidli kahle treatment njengendlela angitshela ngayo ngasuka ngahamba sengiqedile ukungithatha amagazi ngaye kwenziwa kwenye room banginike treatment ngaphuma lapho ngaya kumphathi eroomini yomphathi wabo ngayasho ukuthi ngibe nenkinga ngiphathekanga kahle clinic wathi yini ngathi usisi lo engithatha amagazi kungiphathe yabo thatshele bonke abantu lapho ukuthi ngipositive ngama treatment angidli kahle wathi yena hayi kulungile ngizokhuluma naye.
Oh, okay.
Mina ngangilindele ukuthi uzombiza athi wozala sihlale soba u3 u10 kusisi lo axolise mexolise kodwa azangayenze leyo nto njengomphathi wathi hayi uzokhuluma naye but yakungiphathanga kahle ngangiyazi ngahluna uyibamba inyembezi hayi kwangiphatha kabi sheme umqamba manga ngoba kumina ngedwa ophathana kabi lapha eclinic ukuthi wangiphatha kabi nabanye abaphatha kabi
so
ngiyazi ukuthi ufundile ngoba yena wathatha ngalokho mina nginandaba kusala ngiyahola mase kuphela inyanga mina ngokwami ukuthi vele ngeke kwenzeke ngendlela yami engabe leyo anesu yasuswa eSavana ayiswe kwenye indawo ngoba akwazi ukuphatha abantu hayi ngaze nyeza kodwa manje ngangicabangela impilo yami ukuthi ngeke ngikwazi ukuphila i-treatment enganayo cha ngayinyeza ngimqamba manga.
Ngiyaba ne-experience ngase-Savannah Park Clinic bengiyocollecta i-medication yami ama-ARVs. What really happened, bengihambe nomlungu wami saya ngaseGoli ngakhohlwa ukuthatha i-date yangidlule ukuthi ngicollecte ama-bloods. I was supposed to take my bloods in February, then which means it happened when I noticed that I had to go collect my medication. So when I got there is this other sister where I was sent to go collect the blood samples. When I went there, she said, "You foreigners," she asked me, "Where were you?" I just told her that I went to my work with my boss, like she was transferred to Joburg and all stuff like that. So I missed my date because I was there, but here I am today to do all those and collect my medication. What she stated is that you foreigners, you want us to run around or maybe call you. How am I going to call you because you are from Botswana? How am I going to reach out to you when you are in Botswana to come collect your bloods and all that? You foreigners, you don't like. She just said a lot of things and they are hateful because which means as foreigners, we are not recognized. They take, I don't know how can I say this. It's like they take us for granted or maybe they don't respect us, but we do respect them. So I was hurt by the statement that you foreigners, you have to run behind you to do all about your own health. But what matters is that what really hurts me is that nobody followed me to come do all those. I came by myself and I realized my mistake and I came to rectify those mistakes. But all that, I think it all fell to deaf ears because I really tried to reason with her, but she just kept coming to me, calling me that you Kwerekweres, you don't listen. You have to run behind you to all like, because this is your life. You have to follow it. I said, but if it's my life, I didn't like run away or I didn't stay away for too long. I did come because I know that I have to come collect my ARVs in this facility. That one has to count that it was my first mistake. I've never missed. Even some nurses, they can vouch for me that it was the first mistake I have done since I started my ARVs. I've never missed my dates, no, for blood supplement or for my medication. I was already, like, always on time, always on point, like, always in my dates, I always followed my date. I just missed that, but what I got, it's not really good, really, really good. The problem is you have to accept the situation because we are not in your country. Just, you have to accept the situation to survive. So, yeah, they are hateful, but you have to accept because you can't change all those. I have learned to, like, accept. It's painful, but I have learned to accept.
We now move to community members who have joined us in person today.
Sanbonani, igama lami nguPhumzile wakwaMbambo. Into yami engizoyisho namhlanje imayilana namagazi. Ngisuka eFolweni Clinic.
Phumzile Mbambo, I use Folweni Clinic.
Following clinic sine problem yamagazi abuya engekho right. Kuyasiphazamisa ke kakhulu because sisebenza ne community ngoba awukwazi ukubuye umuntu kade umtracile uyomlanda ubuye uzomlandela ukuthi igazi alikho right futhi.
So the problem we have at foreign clinic when the blood result come back, they are not right.
Yes.
So as the community workers, we find it difficult that we fetch patient from the community, and then when you give them the results are not right.
Ngiyajabula ke ngoba khona ne district ikhona namhlanje ngoba sithe masiyibuka kwenzekile nakumina kumina nje nguphumzile igazi langaba right. So kwangithusa kakhulu ngenhlanhla ngikucwaningo lwakwa Caprisa elaka Caprisa igazi li right. So sinento ethi mhlawumbe ngenzeka ukuthi mhlawumbe amabhodlela abawasebenzisayo awekho right.
I'm happy that the district is here, and because I've also experienced this problem, I also took bloods. When my blood result came back, they were not right. Unfortunately, I'm in a good position because I'm in a research with Caprisa, and the blood result from Caprisa came back different from the one that I took at the clinic.
Nginesicelo ke la kwi district umphako nje engabaphathisa wona nezimoto lezi epick up igazi kungenzeka ukuthi izona thina efolweni imoto ipick up folweni clinic Nsimbini clinic umbumbulo uyayibona I distance le moto ihamba naleli gazi langalibalele mhlambe bangasenzela umusa bayibheke lento and then mhlambe imoto per clinic ezopick up igazi beyodwa ngoba kufanele zigijime negazi ukuze liye lapho.
So we plead that at the clinics or to the district that maybe they can look into the transportation of the bloods, because on our side the bloods are collected from Foloni Clinic and Nsimbini Clinic, and you can see the distance and the travel around with the bloods. That could be the reason why the blood results are not looking good.
Yeah, abantu esibasebenzayo as ama volunteer communities baphatheka kakhulu because konesa basuke bekhona mozobuya akutshela ukuthi igazi lakho alikho right. Omunye uzothi hey indaba ucondomize njengami nje awukwazi ukubusa condomize ngingaka. So omunye unesi ukutshena kahle omunye athi awucondomize awuwadli kahle amaphilisi but nje ama patient awaphathekile kahle.
So due to that, patients are not happy with the result that they are getting, and when you get this result, the nurse tells you that the result of your blood are like this because you are not condomizing. So they either blame you for your result not being what they were supposed to be, then looking into what could be the cause of your blood result to come back the way they come back.
Thank you.
Thank you.
Sanibona, ninjani? Nami ngiyaphila, ngicela anonymous. Okay, mina ngisebenzisa iPoli endala yakwaMashu.
I use all polyclinic at Amashu.
Okay, so ngangeka ku date yami ngelosuku. So ngavuka ekseni kahle nje ngoba kuyavuka eclinic angithi ngavuka mangivuka ngafika ngo6 eclinic.
I woke up early and went to the clinic around about 6 a.m.
Masifika salinda bavula ngo8. Bathatha amakhadi ethu ngo8. Kodwa amakhadi ethu asathola ngo9 ngoba emakhadini umuntu afatha amakhadi ethu bafike lapha emakhadini bexoxele benakele indaba zabo thina simile la.
So they took our cards at 8 o'clock. Then we waited until our card came back to us around 9. Because what happens is that when they take the cards looking for your files, they just stand there and they chat while we are waiting as patients.
Mathela amakhadi ethu sasuka lapho because ngemagazini mangiyafika emagazini iqueue yakhona inde. Masifika emagazini ke sihlale silinde onesi emagazini ke we hayi bandla shame hayi.
So when I got my file I went because I was going for bloods, and I waited there and we waited, and the nurses, when you come for bloods they do their own things.
Masifika sihleli ke aboje amagazini bathatha nga2. Mofika phakathi bayaxoxa sina silindile ngaphandle wani sivukile silambile yonke lento lena nje manje onesi basepholi babona ngathi nje bona bonke abantu ababhizi empilweni thina sikho busy mofika eclinic usukufikile ubhorekile. So
what happens is that they take only 2 patients at a time, and then we continue to wait and wait and wait, and the nurses at the polyclinic, they just act as if the clinic belongs to them, and then when you come to the clinic, it's like you're going there because you are bored and not know what to do.
Okay, sahlala kwase sele abantu abawu2 hayo nurse baye lunchini and mabe lunchini bahamba bonke.
So there was 2 of us left, and they went for lunch, and all of them went for lunch.
Sabalinda mabe lunchini ke mabebuya sathi thina ngoba senibuye lunchini cela isithatha ngoba sesele so2 kwavela kuthiwa se meeting ithi namanje sibize umphathi kwasho waxisha warawara hayibo hayi cha
So when we went back, and when they came back from lunch, when they're supposed to take us and take our bloods, they said they have been called for a meeting by the facility manager and they cannot assist us at the present moment.
ayeke sabalinda ke emagazini kuvala ngo2 bahlala emeetingini silambile thina lana uyaphuma uyothenga uyabuya uzuzele mabebuya bona babuye sebezovala sibeqoqa bethi ngisagoduka thina manje sisiyahamba amagazethi asathola imbuye kusasa uyacabanga uvukile ekseni.
So after the meeting, when they came back, it was already late. They were not able to take blood from us, and we were told to come back the next day.
ayeke sahamba sagoduka savuka ekseni ke safika bathi samagazethi kodwa nje I'm not happy ngepholi and okunye futhi mofika epholi njenge patient yakho nangithi uyagula mofika ukuthi ayi nurse ngiphethwe umkhuhlane ngiyagula akakusizi uvulathi iyaphezulu epholi phezulu ungazi ukuthi kanjani manje phela ngiyipatient la nginike amaphilisi ngiphuze.
So when you go for a chronic medication and you tell the nurse that I have a flu or I have any other problem, they tell you that you must go to the new polyclinic. They will assist you. They don't give you medication as you are required.
Okay, okugcina ngci ngicela ukuthi nje o department nani betshela ama security lapha esangweni ukuthi bengakubuza ukuthi uzokwenzani eclinic because awuzele bona.
So we appeal to the district that they must tell the security guard at the clinic that they must not ask patients what they are here to do because it's none of their business.
Ngibonke.
Thank you.
Small. Igama lami kulindo uhle okwamcuno ngisebenzisa iclinic ehle ngisizwe Hammersdale. Inkinga yami esehle ngisizwe nginenkinga ukuthi njalo mangabe ngiyakhona ngizofika ngenze ifile elisha yabo and ukwenza ifile elisha uyahlala la kwenziwa khona amafile ugcine kwesinye isikhathi ungasizakalanga yabo nje inkinga enginayo nje mina inkinga yezi
clinic. Every time when I go to the clinic, I have to open a new file.
Yebo inkinga enkulu ke enginayo yile ukuthi ehle ngisizwe udokotela wamazinyo uthatha isibalo njengoba ethatha isibalo uthatha isibalo futhi osibona kahle la ukuthi lesibalo lesi asikho ngeke uthatha abantu abawu20 izinyo enye into leyo enye pain leyo yabo.
The doctor there takes only a certain amount of patients to work on that day, and they only take about 20 patients. So 20 patients is a very small number because the pain of having a toothache is not bearable.
Yes, uthola ukuthi ngaleso sikhathi wena njengoba ifile lakho bengalitholi usenza leli file leli ufike early vela ngithi wazi ukuthi udokotela uthatha isibalo mangabe kwenziwa ifile ukhamba kwesikhathi lokho la wenza khona ifile bengakubhaleli ukuthi uyowenzani yabo bathi uzofika ubhalele udokotela uma ungabe ufika lapha akusamele uqale uyocheck ushukela ngesikhathi uzokhipha izinyo yabo isikhathi leso uthi usuyafika usulindile lapha usubhaleliwe yonke into kodwa bayazi ukuthi bona udokotela uyahamba ku9 noma meqeda lo20 wakhe uyahamba wena usuyasala ke lapho.
So we plead that if they can make things quicker for us when we come for our tooth to take out our tooth or for a dental assistant, that they make the things quicker because it's a long process. You have to check all the vitals first before you go to the doctor. By the time we finish with the vitals, the doctor already has a certain amount of patient that he has to see.
Hayi angikona nje lokho ngifuna nje uqembu mangabona bayasebenza impela kodwa nje inkinga iba lapho kudokotela lo wamazinyo izinyo enye pain le engabekezeleleki ade kubhlungu nje nayizolo nginibuka nidla ama desserts bazalwane.
So that's all. We will plead that the doctor maybe increase the number of patients that they see. Thank you. Thank you.
Thank you. Thank you. I think as we go into the recommendations, we need to applaud the 35 facilities which are doing well. Department of Health. But also there are those facilities which are underperforming. I think it is important that the department is working with those facilities to make sure that they meet the standards of the other 35 which is doing well. Because that is our wish, to make sure that all our public health establishments are providing quality services to us. Also, it will be good if the authorities from the department can work with us and the healthcare workers to make sure that stigma, discrimination, and involuntary disclosure of people living with HIV and key population is coming to an end. Because if me, Anel, as a person living with HIV, I'm not comfortable to disclose my status, it does not give you a right as a healthcare worker to disclose my status. And legally and otherwise, if our people were empowered, they can sue those people as individuals. Now, you are no longer suing the department, you are just suing the person who disclosed your status without your consent. That's not what we want. But also, it is important for the department to have these sessions of sensitizing the healthcare workers in order for the healthcare workers in our clinics to understand that we, as the public healthcare users and citizens of South Africa, those who work in South Africa and those who stay in South Africa, we've got rights. We've got constitutional rights. We also have patients' rights in the charter. But most of the times, our healthcare workers are not adhering to what is in the Constitution and what is on the Patients' Rights Charter. But also, in some of our clinics, you have your suggestion box, your complaint boxes. Those things do not help us. Because normally people lay complaints, but nothing is happening. You know why? It's because, I'm making an example, it's because the facility manager belongs to another union and the majority of other staff members belongs to another union. So when the facility manager starts acting, it's no longer an issue of the facility manager, sebefaka ama union. But what are the standard operating procedures of the department? How often does the department make sure that all its employees, they adhere to the standard operating procedures, irrespective of which union one belongs to or not? These are the things which we think we need to work with the department. And it will be good at times, our party, to invite us as users of services when they have meetings with staff members, so that we are able to give testimonies of what we go through in a particular facility in the presence of the workers. It is always good when it is coming from the mouth of the horse, including issues around medical xenophobia. These are the things that we cannot tolerate in South Africa. But we have been calling for the department at all levels to work with us in making sure that we sensitize the healthcare workers. Because if we as the public healthcare users, we can decide, like others have decided, to stop engaging with our facilities. If all of us, we can decide for a month to stay away from going to clinics, they won't have work to do. And what will be the reason for the government to pay them for not doing anything? We are their clients. We are the reason they are employed. We are the reason they are getting paid each and every month. But if we as clients are not satisfied, what can be done to make sure that there is satisfaction of the users of the healthcare services? You know, in South Africa, not long ago, few years back, there was a state capture commission about Indaba yabo Zuma and the Guptas. And I'm asking myself whether if we can call for a commission of inquiry on state of the public healthcare system in South Africa, will that help? Where we push for our government to give a platform to the public healthcare users, like publicly, the way Abozondo Commission will do, so that we can tell the country, we can tell the world about the frustrations that we're going through. The reason in South Africa we've got the highest number of people who are lost to follow up, who have defaulted on treatment. People are giving testimonies with why they decided not to go to clinics. And all other interventions the department will bring, as long as they do not address these underlying issues, it's just waste of time. Instead of the government coming up with other interventions, I think the first thing that they must do is to listen to the people. If our government officials and the government itself can give themselves an opportunity to listen to us and try to attend to the problems that we are experiencing, I'm sure there will be an improvement in terms of the second 95 and the third 95. But if what is being said here and on the videos are not attended to, many people living with HIV will continue disengaging from care because of what we go through when we go to these facilities. Like, for instance, it is not wrong for us, whether you are using healthcare services with private or wherever, it is not wrong to miss an appointment. It's not a crime. Like, for instance, here, we were supposed to start at 10. Other people arrived late. Those people who arrived late, we never shouted at them, "Why did you arrive late? Go and sit at the back." But when it comes to us as the users of services, you miss the appointment with 1 or 2 days, you are being shouted. You are being punished for not pitching up on the day of the appointment, irrespective of his cut-off ngaso. The following day, even if you can arrive at 3 a.m., when they start working, they will tell you, you missed your appointment, go and stand right at the back of the queue. We know our clinics. Between 8 o'clock and 1 o'clock, our clinics are busy and congested. But after 1, our clinics are not busy like that. Why don't we come up with strategies to say, all those people who might have missed their appointments, instead of waking up as early as 6 a.m., you must come to the facility after 2 o'clock, and then we will give you your medication. So I think we need to be innovative, because at the end of the day, these standard operating procedures, it is not something that is coming from heaven. They are crafted by human beings. And it is human beings, again, who can amend them in order for them to be favorable to our conditions. People are waking up as early as 4 a.m. Queue in those gates. Already you have spent 3 to 4 hours waiting outside. They start opening gates, and then they start collecting your medical file, and you will be attended around 9:30 to 10. But by the time you walk out of the gate, they will have went to lunch intervals once or twice, tea time and lunch time. When you have been sitting there, hungry, frustrated and all that, and they don't put themselves into our shoes. We are poor. That one we cannot run away from. We were colonized. When we were colonized, before they took our land, they took our dignity. And then after taking our dignity, they took our land and the livestock. And we do not expect that we are ill-treated like this by people of our color, of the same skin pigmentation with us. And these things can be resolved. All what we want is to embrace empathy and humanity. And I hope that my brother, the one onenkinga yezinyo, abaphathi who are here will attend to that before we leave here. So that when he leaves here, he knows that tomorrow or today, he goes to the nearest facility to take off his zinyo lakhe. Because we are not convening these meetings just for fun. We are convening these meetings to make sure that if there is someone in the house who's got a problem, who didn't get medication and all that stuff, our party who are here are doing something about that. From where I'm seated, I am the General Secretary of TAC. Whenever there is a problem, I put policies aside and embrace Ubuntu and say this and this must happen like this. And from where I am seated, I am sure my party, Nani, you can do that. All what I'm asking for is for you to use powers vested in you to make sure that you are different from what we are seeing in facilities. To make sure that whenever we have problems, we know that you are always there and you will listen to us. And then after listening to us, you will use powers vested in you to make sure that everyone who is here, Okumphakathi, is happy and satisfied. The reason I'm saying this, colleagues, I normally attend the meetings of the Health Portfolio Committee from the National Assembly when we go and present our reports. There was one member of parliament from the Democratic Alliance who said in a meeting, South African government, you're talking about NHI. It has failed before it is implemented. And then others started shouting at him. And then he was given a platform to say, the reason I'm saying this, South Africa is failing the people of South Africa on the HIV program. And if you're failing only about less than 5 million people, how do you expect to provide quality services to 42 million public healthcare users? Can we work together with our officials and not give a reason to those who do not want the NHI to be implemented? We must not give them a reason to argue. We must work hard to make sure that we improve the quality of services for our people. Issues of infrastructure, human resource, we need to be able to separate what are the problems between provision of quality services, dealing with staff attitude and all what have you, and also attend to issues of human resource, shortage of medication, blah, blah, blah. But we cannot have these problems and also have problems that are not created by the system. Staff attitude is not created by the system. It is a choice that an individual takes to ill-treat the people. And not all healthcare workers are the same, but it is important for us to work together to eliminate these rotten potatoes, because it is these rotten potatoes that makes us here in this room and in community to have a negative attitude towards our clinics and towards the health system in general. I humbly ask that we work together. You know, from where I'm seated, one thing that I know, in this community that is here, if inkinga yomntu one can be resolved, even if it does not affect me, we will be happy because we see that something is being done. But also, when the interventions are made, if feedback is not forthcoming, is not given to us so that we can be able to say, based on this problem, this was done. And if we can work together in this district of eThekwini with its district management team, so that we get the feedback about these complaints, we will be the ones who will be the ambassadors and who will defend the district to say, we had this problem, and eThekwini district management did 1, 2, 3, 4 to address this. Therefore, it will mean when we come here to these meetings, you know that we are not coming to these meetings only to raise complaints, but we are also coming to these meetings to give a feedback about progress made, about issues that we raised previously. Going to the recommendations, the Department of Health should ensure the DOH staff acknowledge that it is normal to miss appointments and or have treatment interruption. People living with HIV returning to care after a late or missed scheduled visit silent transfer from another facility or treatment interruption should be welcomed. Ensure Department of Health staff treat people in a dignified and friendly manner and investigate any reports of poor attitude raised by Ritshidze and take disciplinary action where appropriate. Send communication to all sites highlighting that no person living with HIV should be sent to the back of the queue if they are late for or miss an appointment as per national ART guidelines where no punitive action should be taken. Ensure transfer letters are not to be required for ARV continuation or restart. Any reports where treatment is delayed by requirement of transfer letters should be urgently investigated and disciplinary actions taken where appropriate. Implement the 2023 adherence guidelines standard operating procedures with fidelity, including ensuring every person starting ART is provided with good quality, fast-tracking initiation counseling session 1 at ART start and session 2 after 1 month on ART. Taking first viral load as early as possible to ensure providing earlier adherence intervention support and earlier access to longer treatment supply at more convenient locations. Actioning and alleviating an alleviated viral load without delay, including funding and setting up effective abnormal results recall system and providing quality enhanced adherence counseling when appropriate. Actioning a suppressed viral load without delay, focusing on immediate assessment, offer and enrollment into the repeat prescript collection strategy of choice the month after a viral load is taken. All facilities implement 2023 re-engagement algorithm, including appropriately differentiating services for returning people living with HIV. Ensure the Department of Health and district support partner staff provide accurate and easily understandable information on treatment literacy and adherence, and the importance of undetectable viral load through consultation, counseling, and outreach. Ensure that treatment literacy information is provided at health talks each day at the clinic. Ensure that Department of Health and district support partner staff explain viral load test results to all people living with HIV properly in a timely manner. Ensure district support or health systems trust should ensure district support partner staff acknowledge that it is normal to miss appointments and or have treatment interruptions. People living with HIV returning to care after late or missed scheduled visit, silent transfer from another facility or treatment interruption should be welcomed. Ensure district support partner staff treat people in a dignified and friendly manner and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary actions where appropriate. Support with training and mentoring of DOH staff at facility level on revised 2023 re-engagement clinical and adherence guidelines standard operating procedures.
The next group of issues are those affecting the key populations. Most key populations are using public health facilities to access their health services. So it is important that our clinics and our community health care providers provide a friendly, respectful, safe, and confidential environment for our key population. Yet, despite sensitization trainings and retraining efforts, disrespect and poor treatment of key populations remain a common challenge. Ritshidze data reveals that at public health facilities, only 33% of gay, bisexual, and men who are having sex with other men, 32% of people who are using drugs, 40% of sex workers, And 35% of trans people reported that their staff are always friendly and professional. Where the attitudes of clinic staff have become unbearable and some people have stopped going to the facility altogether. Clinical staff were again this year the most commonly reported as being unfriendly and unprofessional by all key population groups that were followed by security staff. The majority of key populations that were interviewed did not feel safe or comfortable at these facilities. In order for our key population to access health services, and in a particular key population-specific services, spaces are needed that are making them feel safe, comfortable, and private enough for them to disclose that they are a member of a key population group without a fear of being judged, abused, harassed, or even arrested. Disgraceful privacy violations continue to occur that destroy people's rights to privacy. 37% of gay, bisexual, and men who are having sex with other men, 44% of people who are using drugs, 38% of sex workers, and 33% of trans people interviewed did not think that privacy is well respected at the clinics in eThekwini district. Shockingly, some people even reported being refused access to services in the last year just because of being someone who uses drugs or being someone who is a sex worker, including 20% of people who are using drugs and 6% of sex workers that we interviewed. This is unconstitutional and absolutely unacceptable because everyone has a right to healthcare services. Where people do continue to suffer the daily indignities and using the public health system, specific services remain unavailable. Ritshidze data reveals that a very few sites provide KP-specific services. And when asked about those specific services, what they are, it becomes very much clear that there is little available to none. Key populations can't always access basic prevention tools like condoms and more especially lubricants. Lubricants were only available in 21% of sites that we monitored. Additionally, lubricants need to be put in places where people can take them without being judged, embarrassed, or even ousted as a KP. However, in some sites, where they were available, lubricants were only available in the main waiting area where everyone can see you trying to access them, or by the reception area, or by request in consultation rooms. When we spoke to KPs themselves, only 29% of gay, bisexual men who are having sex with other men we interviewed, 40% of people who are using drugs, 52% of sex workers, and 51% of trans people using the public health care facilities said that they could access lubricants. Not all facilities do prioritize offering key populations PrEP, despite it being available in 100% of the facilities monitored by Ritshidze. So if you do not know about PrEP yourself, you are more likely to never know about it because this is not being offered. While covering a wider and different set of sites, only 14% of gay, bisexual men who are having sex with other men, and 9% of people who are using drugs, 15% of sex workers, and 37% of trans people that were interviewed reported being offered PrEP at these facilities. Pointing to the reality that while PrEP is sitting in the facilities, key population are not always made aware of it and actually offered PrEP. The majority of people that could access the contraceptives they wanted, but at times KPs are refused access to contraceptives, specifically because they are a member of a certain key population group. As reported by 43% of people who use drugs that were interviewed. South Africa faces a well-documented epidemic of gender-based violence, including homophobic, transphobic attacks on LGBTIQ+ community members. Sex workers also face extreme levels of violence and forced to have sex at the hands of their clients, partners, and even the people who are meant to be protecting them, which is the police. It is critical that the key populations who face sexual violence feel safe enough to access the necessary services at the clinics. However, only 26% of gay, bisexual, and men who are having sex with other men, 51% of sex workers, and 27% of trans people thought that the staff were well trained to care for those who have experienced violence. Harm reduction services remain out of reach for people who are using drugs. Only 9% of people had been given information about where to access new needles. Only 12% of people had been given information on where to access methadone. And only 7% of people were able to access drug dependency support. Gender-affirming services are critical, yet only 22% of trans people say facility staff are always respectful of their gender identities. 78% said that the healthcare providers use their wrong names, and 56% said that they use the wrong pronouns, like calling me a she instead of a he. 80% of trans people who we spoke to wanted to access hormone therapy at the public facilities, and most clinics were unable to provide information of trans people about where to find these services. Now we are going to move on to the recorded stories.
I identify as a transgender person. My pronouns are she and her. So I'll share my story on how I was denied access for medical health care. So I used U21 clinic as a place where I access medical health care. There was a time whereby I attended psychosocial supports in order for me to access HRT. My doctor asked me to use my nearest facility and gave me an injection with a note on how they must inject me for HRT because it was an injection. So they denied. They were busy calling each other. Well, you no, we are not allowed to do that. It's no, nanje inothi yasho from udokotela uthiwa ngizonikeza unesi. Unesi uzowazi ukuthi uzokusiza kanjani. So ngangakwazi ukuthi ngithole lelo sizo lelo. Ekugcineni I had to take ulokhuzi u-arts khona la kule facility. Angisakwazi nokuthi ngithathe no-arts manje, and then I decided to move. Ngisebenzise i-drop-in center because I was introduced to a drop-in center of which oram pop-in, and then I'm able to get hormones and no atwami kahle, and service delivery is very, very good. But then check service delivery, I say U21 clinic was very, very bad. There was a lot of discrimination, which I saw that it's happening to mostly people who are trans and gender diverse at the facility. So that's why I decided to leave. Having to be denied the access lapha e-U21 clinic akungiphathi kahle because ngiyabona ukuthi iningi into esafanele ukuthi yenziwe ukuthi kulungiswe indlela abantu abasiphatha ngayo mas attenda e-clinic, because le clinic it's the local clinic which I must use. Ngingaze ngishonele eFlorida because eFlorida kuyabiza kunama cost. Angeke ngize ngikwazi ukuthi abanginikeze imali for ukuthi ufikele uzothatha medication yakho, and ama follow up they are very important. So having to travel, we are ku-Florida ngibe ngihlala la eMlazi futhi nawo wonke ama-service engiwafunayo vele e-U21 clinic angeke ngize ngiwathole wonke. Awekho ama-lubricant lapha namakhondomu uyanqena nanokuthi uwathathe and ngathi wona futhi nonesi abawazi nokuthi yini kwayona lawo ma-lubricants. Wayengifuna izinto zey'tabane manje ayikho le nto la fanele bangazi uyoyithenga ko-Clicks what into engabe siyayithola is then ka-Oram ngiyakwazi ukuthi ngikwenze konke lokho ngithola yonke into engiyifunayo. So I'm very happy ngawo Oram Pop-In. So vele u-21 I don't think I will ever use it again because now I'm introduced to drop-in sense. Yes, that was November, yes, 2020, yeah. Until I was able to access HRT last year, 2022, around September. Until today, I am able to access HRT, including arts. From November 2020 until ngize ngikwazi ukuthi ngi-accesse last year 2022 September. All this time I had to stop using u-arts, and then the time ngifika kwi-drop-in center ngafika ngawo umuntu engathi angazi ukuthi vele ngi-diagnose, and then ngaqala lapho ngemaphansi sengena kwenye treatment. I never told anyone about that. Kwakuyinto nje engiyibekele mina ukuthi no, how am I going to say so. Ilokhuza ngangiworried ukuthi hayibo mhlambe nje ngizobetane ngigule nje once ngibetane ngithule straight, but then ngiyabonga ukuthi zange ngize ngigcine ngize ngishona-ke ngoba phela isikhathi eside lesi bengade ngingayidli medication because le u-21 bebengajwayele mhlawumbe ukunginikeza for months, kanti la ka-Oram Pop-In ngiyakwazi ukuthi beze nginikeze medication almost even 6 months ngize ngiqhamuke sengize nje follow up mhlawumbe noma ngiyothatha amagazi.
Igama Anonymous. Umsebenzi wami engiwenza ngisebenza emgwaqeni. Ngisebenza emgwaqeni. Okubuhlungu ngathi thina senze emgwaqeni kuyo yonke indawo la esihamba khona abasithatheli. So XI yakhona bekade seyinuka to a point ukuthi bengisabuke esibhedlela. Ngathi mangifika khona esibhedlela bathi onesi bengihlaleleni isikhathi eside kangaka ngazi yini fanele ngisebenzise icondom in and I was like hayi ngoba nakho icondom bengayisebenzisi bengiyisebenzisa, but emva lokho kunokuthi bangisize bakhetha ukuthi bangidelele bangimemeza ngayo bangibiza ngayo wonke amagama. Lento yenzeka ngoMay 28 eRK Khan. Yeah. Lapho nakhona ngagcina ngiphumile ngatholanga usizo ngaze ngasizakala kathi BK. Lezo azitholakali kalula, especially mawuqhunyelwe icondom. There's the thing ukuthi mawufuna amaphilisi kubona bakutshela ukuthi hambe wathenge echemist. Kungajabulisa khona mangase ngelinye ilanga bakwazi nabo ebhedlela bakuthi babe nawo basikwazi usinikeza if siwacela bengasinyasi if ukuthi mhlambe sinezifo esinazo zangaphansi zasemzimbeni, like ngoba yonke into ephathelene nomuntu ophantayo emgwaqeni ayikazi yathathelwa entweni ayibhekelwe entweni. Yeah.
Yebo, ngisho igama lami ngina 37 years old, ngwaseHammersdale ngokuhlala, kodwa manje sengihlala eThekwini, ngihlala AK Block Shelter igama layo. Ngafika le eThekwini before lockdown 2020, ngayithwele lockdown 2020 ngahlala ke lana ke ngagcina sengithola indawo ye-shelter ke. Emva kokuthola i-shelter ke ngathola ukutesta ngathola ukuthi ngiyi-positive nge-HIV positive, then ngaqala ngathifuna indawo ngizothola kuyona indawo ukuthi ngithola amaphilisi ami ke ngasebenzisa iDenisali ke ngoba yona indawo bengiyazi ngoba ngathola la ke la eThekwini ukuthi ngiyi-positive ngancamela iDenisali ngaya ke iDenisali ngayo thatha amaphilisi ami ke lesi sikhathi sonke lesikhathi lo ngithatha amaphilisi ami agcineni sengiba nenkinga nga 3 months back nomunye usisi osebenza khona ngiyasaba ukusho igama lakhe kodwa uyi-staff member sakhona agcina sengasakolanda amaphilisi for 3 months sengiwacela kubafethu amaphilisi ukuthi bangisize njalo nanjalo kuba wese yabo nje nganayo igovernment ingayithathela phezulu indaba yale nto bafethu yethu yabo.
Waqale ngami. Sanibonani, uLulu lokaMgoza, I'm from Hammersdale. Clinic engiyisebenzisa engangiyisebenzisa eMpumalanga Clinic.
From Hammersdale.
Ngangisebenzisa eMpumalanga Clinic.
I used to use Mpumalanga Clinic.
Yeah, thank you. Inkinga nje yaseMpumalanga Clinic isikhathi. Okay, fine. Nganginenkinga sexual, so I was bleeding after I had an intercourse, and I had been bleeding for like 6 days.
I had a sexual problem. I was bleeding for about 6 days.
Ngangithukile kakhulu because I didn't ngangazi ukuthi ngiphethwe yini at that time, but ngokuhamba kwesikhathi ngathola ukuthi I had fisters. Ngahlala kakhulu ekliniki. Into engenza ukuthi ngibe frustrated ekuhlaleni kwami because ukubleeda kwami kwakudinga ukuthi ngifake something because kwakuyinto enganqamuki.
I was heavily bleeding. I had to use something to stop the bleeding.
Inkinga yami yama-toilet akhona angazi ukuthi kwenzakalani ngendaba yama-toilet kuma-facilities. At least it would be better if beba nama-gender neutral signs because lapho nje I felt very disappointed ukuthi angikwazi ukusebenzisa even a toilet ngiyise-clinic, so I had to sit nalelo gazi lelo laliphuma. And then
happy with the toilet condition at the clinic, so I had to sit with the blood, and I wasn't able to use any toilet for helping myself since I was heavily bleeding.
So inkinga ke mase ngifikele ku-nurse ngiyamtshela inkinga yami usebiza abanye ozakwabo hayibo uzongizwisa.
So I told the nurse about my problem. She then called her other staff members to come and to hear my problem.
Ekugcineni ke abazange bangisiza bathi asazothi uphethwe yini, so asazi nokuthi sokunikani, so usizo ngagcina ngilithole esibhedlela.
So I was not a sisters. The nurse told me that they don't know what's wrong with me, so I then left the clinic without being helped.
So into engifuna nje ukuyibuza cause bakhona health ukuthi abaka health bafundise staff sabo noma basensitize cause mangise ngize clinic angizela ukuthi uzongijudge ukuthi ngiphila impiloni, and akuyona indaba yakho ukuthi ngiphila kanjani noma impilo yami yini engiyenzayo ngempilo yami. So
to plead with the department that they teach their staff that when I come to the facility, it's none of their business what kind of life that I live, but for them to give me the kind of service that I need.
Okugcina ngaze ngimosha isikhathi umngani wami waya eclinic eyofuna ama-lubricant bangamnikeza onesi abayeka attendance noma anyone in the room yokuthi the gays, the trans, the lesbians banemali cause ama-lubricants ayatholakala eclinic, but uzongitshela ukuthi angihambe ngiwathenga because uthi nginemali. Thank you.
We plead that we are not rated, that we have money, and we are told to go buy lubricant as we know that they are available at the clinic.
Sanibonani. Ngicela ukuba anonymous. I'm one of ama sex worker. Ngiye ngaratio ama client awu3 ayongilahla
I'm a
elwandle.
sex worker. I was raped and I was taken to the beach.
Mangisuka lapho i-nearest isibhedlela besiseduzane eDingsini. So I went to Eddington Clinic ePoli. Mangifika khona ngireporta icase yami. Kwakukhona osista sebekhulile omama abadala. Kunokuthi bangisize babizana bodwa bahlala ndawonye bekhombisana ngami. Beyitshela ukuthi bengivele ngiyicelela ukuthi ngiresho. Ekugcineni
So when I went to the clinic for assistance since I was raped, the nurse started calling each other, telling them that I asked for this to happen to me.
and islow salokhu sihleli silindile ebhenchini sicabanga ukuthi mhlambe khona usizo oluzotholakala bahleli baphuzite bakhombana ngami ngibuza security kusikodwa baba mhlambe ngabe khona usizo soluthola asilo baba bubuso ngiyoba kusiyoqwayiza yoma emgaqweni ngimphendule baba ukuthi nami khona ingane ezidla njengoba ngimla emgaqweni.
So then I sat there waiting for help and I did not get help. When I asked the security, is there any help that I'm going to receive? The security answered back to me, said, who told you to go be a sex worker and work in the streets?
Lapho ngilimele ngireshiwe ngiphelezela umngane wami usizo ngaze ngalithola ka CBK morning side. Ngiyabonga.
I did not get any help. I only received help from TB, HIV, and Morningside.
Nginibingelele. Mina ngisebenzisa u21 clinic. So inkinga yami enginayo ukuthi ama periods ami are abnormal. So
U21 clinic, my problem is that my periods are abnormal.
okay. Mangabe ngiya lapha kwi facility ngibachazela isimo sami because it's about 6 years now mangaphosisa. So mangiya khona bathi nginormal. Bajaja ngisho even iphandle ngangiyifakile because ngangisanda kuphuma endumbeni ngaleso sikhathi. Bathi igazi livala abantu abadala.
So when I went to the clinic, asked for the assistant, they told me that my bleeding is normal, and they were judging me since I had cultural bells in my hand, and they were telling me this is being caused by my ancestors.
Yeah, and then bangifasa ukuthi ngenze i-preg test. Noma bazi ukuthi ngiphila impilo kanjani. Base bangifasa ukuthi ngenze i-preg test. Mangibatshena ukuthi
Forced to do a blood test.
preg test.
Preg test.
Noma ngibatshenile ukuthi ngiphila impilo kanjani bathi since ngiyintombazane kumele ngiyenze. Bathini bathi ngenze ukuthi ngikhulelwe.
So even when I disclosed to them what kind of a life I'm living, but they were still forcing me to take a preg test and told me that it might be that I'm pregnant.
Okay, mangenza i-preg test yabuya i-negative. So mayibuya i-negative sebeyasho ukuthi ayi negative. Ngiyabatshena ukuthi okay fine bengazi sizobuya negative. So nangifosa kwamele ukuthi ngenze because ngidinga usizo.
The test came back negative.
Yeah, okay. So emva kwalokho bathi kumele ngifike ne-relative. Ngababuza ukuthi mangifika ne-relative igazi lizoba normal yini? Abakazange ungiphendule.
So I was supposed to come back with a relative, and I asked them if I come back with a relative, is it the blood bleeding gonna be normal?
Yeah. Noma ngibatshena ukuthi mangabe ngikuma periods usuku lomqala luyangwisa and ngiyabuyisa.
So when I told them when I'm on my periods, the first day of my periods, I fall and I get very weak.
Okay. Ngabacela ukuthi banginikeze iletha engizwa ngayo emshiyeni ukuze bezo-check isinga sami because ngiyasaba ukuthi ngenzeka ukuthi ngine-cancer.
So I asked them to give me a transfer letter to go to the hospital because I'm scared that I might have cancer.
Okay, banqaba ukunginikeza bathi bebethi nginormal ngoba ama-hormones ami ayashintsha sithi ngiphila impilo kanje.
So they refused to give me a transfer letter. They said it's because of my hormones are changing because of the life that I'm living.
Okay, kuze kube namhlanje angisayisebenzisi iclinic, angisayinhlobo nje iclinic because noma ngiya kuma-mobile bangitshela into eyodwa.
So today I'm no longer using a clinic because it's the same story over and over again.
Okay, ngiyabonga.
Thank you.
Sanibona. Ngisebenzisa iclinic ya Q. Ngangade ngayile kwadlula usuku lami lokuyolanda amaphilisi.
I use Umlazi Q clinic.
Onesi bangitshela ukuthi ngizolinda cause ngidlulise usuku kumele ngiyolanda ngalamaphilisi. Ngalinda ke mengilinda kuthiwe angilinde cause mina sengidlulele usuku.
So I missed my date to collect my medication, and the nurses told me that I should wait because I've already missed my date.
Kwagcina sekufika la ekutheni khona ekhuluma amagama amabi washo ukuthi vele lenhlobo yenu eyitabane yikho nibangaka medication vela niyilandi uzokulindeke.
So then they started calling me names, telling me that because of the life that I'm living, it's natural that we don't collect our medication. So I have to wait until they help me.
Kagcine sengigodukile ke because isikhathi wayesengasanaso sami nabantu ababehlele eceleni kwami behleka ngahamba ngaya kamnganami ngicela ukuthi angiphe amaphilisi.
So I went home without getting my medication because I was being a livestock. People around me were laughing at me, and then I went home. And asked my friend to give me some medication.
Ngamcela ukuthi angiphe amaphilisi for isonto ngizobuyela sekuphelele lo sonto ekliniki mengibuyela khona ngathola unesi right wangisiza.
So when I asked my friend for medication for about a week, she shared with me, and then I was able to go back to the clinic after a week, where I found a nurse who assisted me.
Lokhulumayo uHlengiwe wakaChamani Sibongo. Mina ngihlala kwaElkamashu. Iclinic engisemisayo iPoli.
Hlengiwe Chamani using the polyclinic from Amashu.
Njalo nje mangithandaza ngiyangithandazela ukuthi ngathi ngingegule ukuze ngingayi esibhedlela noma eclinic.
So every time when I pray that I can never get sick because I don't want to go to a clinic or hospital.
Ngoba ngaphandle kwalokho kufanele ukuthi ngiyimisele ukuthi ngizoba umbukiso, ngizoba inhlekisa futhi ngizoba angazi ukuthi ngabala ngithini.
Because if I get sick, I become a laughing stock. My status is disclosed. People know everything about me.
Angazi ukuthi uhulumeni angeza kanjani ukuthi nathi accommodate entweni enjengazo ama services akhe ngoba manje uma ngabe sifika lapha yana siba nenkinga kabi. Ungena nje ubukwa phansi uziyophunywa phezulu. Uaddresswa uzothiwa bhutisisi usho wonke amagama. Laba abantu abahleli nabo la uhleli wedwa abantu bayahleka yabona nje vele usuya phakathi nje examination room vele nje usuphumile vele.
So we plead to the government that they may accommodate us at the facilities, that we may have our services when we get there, because we become a laughing stock. People know everything about you before you are even assisted.
Ubone ngesikhathi uhleli abanye betreatwa uthola ukuthi mhlambe onesi ababili noma kodwa mase kuza wena ngoba kade ubuni akala ushendele uza sekuzoba inqwaba ezoba khona usuzophendula yonke imibuzo kuzofanele ukuthi bapintshele khoneni ukuthi bazi ukuthi kanti wena kahle kahle uphila impiloni ngenxa ukuthi wena ufike la eclinic uzocela usizo. Mina nje ngoFebruary ngeke ngaba nalo yonke inkinga ukuthi.
So when you go to the facilities, you can see that other patients are being treated by one nurse or two nurses, but when we go to the facility, inside the consultation room, you find that they have called each other. There's more than two nurses because they want to ask you questions, you have to answer about the life that you're living.
Mina ngeke ngaba nenkinga ngoFebruary ngiphethwe isinye. Ngahamba ngaya eclinic. Mangifika eclinic ungibuza ukuthi umlingani wami uyayisebenzisa yini condom. Sekufanele ngichaze ukuthi mina kahle kahle ngimi kanjani ukuze understand ukuthi lokho akubuzayo it's not applicable kumina when it comes to my life.
I got sick, and when I got sick, when I went to the clinic, they asked me that, does my partner use a condom, even though they could see the life that I'm living.
Lokho ke manje sekusho ukuthi noma ubani ola endlini akangibuze uma umbuzo nje awuthandayo noma umbuzo angazi ngawo kusho ukuthi kahle kahle mina sengifikele ukuthi ngizo educate abantu balana ngale uhulumeni engabe uyena owenza leyo into. Ilapho la ngagcina khona sengibatshela ukuthi abakuglishe koma Google bazokuthola yonke information ngoba mina angimisela angizele kona akusona isikhathi nendawo ukuthi ngidisclose yonke leyo into because
So when I go
wonke
to the
umuntu private.
When I go to the facility, they're asking me questions. They're asking me the kind of life that I'm living. And it's like I had to educate them about the life that I'm living. And I had to tell them to Google and find that what do we do being the person that I am, what kind of life that I live, because I'm not here for that. I'm here to get medical service.
Gcineni ukuthi ngiyakhathazeka ngoba angazi abanye baye bayiphendulele kanjani abanye abafana nami abakuleyo kinga le engiba kuyona.
So what worries me, I don't know how other answers to all these questions because I was able to stand for myself and not answer all the questions you were asking me. Thank you.
Sanibona. Igama lami uNkosinathi Mtolo. Mina bengicela nje ukuqala la bazalwane. Ngicela ukuqala ngibonge uRitshidze. uRitshidze mina ngokwami angiboni ukuthi usisiza ngama facilities kuphela. Mina ngazi ukuthi ukukhuluma kuyalapha. Yabo njengamanje njengoba nje ngilalele la sonke sikhuluma kanje ngizizwa ngilapheka.
So my name is Kwasnati. I would first of all like to thank Ritshidze for the work that they're doing. They do not only monitor facilities, but being in this kind of space, it's very helpful that we are able to open up and share our problems.
Ya mina ngisebenzisa i11. So e11 ila engisola khona medication yami. Mina ngi-drug user.
I use Heaven. It's where I get my medication. I'm a drug user.
So i-medication engisebenzisayo mina ikwazi ukuthi ngivumele ukuthi ngingayiphuzi mhlambe kudlula usuku ngoba ngiyagula.
So the medication that I use, I cannot skip even a day without taking it because I get sick.
So ke lapha eclinic yethu sinenkinga yama file ubaba wethu sikhiphela ama file ave nenhliziyo encane. So sekuze kwaba nomthetho ukuthi uthola 2 weeks punishment for i-treatment yakho.
So
2 weeks.
We have a problem with in our clinic. The person who gives that file is very short-tempered. So now there's a rule that is made that if you do not take your medication, you get a punishment for 2 weeks.
So nami I will be starting my punishment soon. So bengifisa nje ukuthi ngoba kunabafowethu laphana ningasenzeli mhlambe mina kuphela yabo kunabafowethu abakhona laphana ngiyacela ukuthi bafethu nizame ukubasiza at least if it's kube nenye indlela ekusebenzeka ngayo lapha.
So I'll also be starting my punishment soon. So I would like to plead that we get help because it's not only for me but for my other brothers who are out there who needs help.
Sanibona. Igama lami uThedi ngwakamthiyane from Kamakhutha.
My name is Teddy Mtiani from Kamakhutha.
I don't have a case as serious kangako but clinic yami engisebenzisayo kwathi the time I was diagnosed ukuthi I am HIV positive. So the nurse or the counselor that was assisting me, she did something of which by the time naganga uguti is it wrong, and I didn't know that files for people who are HIV positive are differentiated with colors. So the nurse gave me a blue card that is used for men. So by that time I didn't know, so I didn't have a problem with that. So when time goes on, I found out that the files are differentiated. So if you are a female, you are given a pink card. If you are a man, you are given a blue card. So now this thing is bothering me. So I never got a chance to go to the clinic and ask them why she did that. Because even anyone who can see me, you can see that I'm a woman. Yes, I'm a trans woman, but you can see that I'm a woman. So the nurse, I think and I believe that she should have given me a pink card that is used for females. So in that case, I don't know what I should do, whether I should go to the clinic and ask them, then come back with a feedback. I don't know who I can take that feedback to and ask them why she did that because obviously she saw that I'm a woman. So I don't know why she gave me a blue card that's used for men. So in other ways, she judged me already, or she discriminated me already. She didn't care. She saw that I'm a woman, but I think she knows, or she took it in her head, but that I was not born a woman, that I'm a trans woman. So I think that's why she did that, and of which I think it's very wrong. Thank you.
Thank you. Thank you.
Yeah. So, we are going to the recommendations. Zam, Comrade Simpiu, Kukusis Wamlo, the one who is a sex worker. Before we leave here, I would like you, comrades, to take it details and meet with district manager. We need to make a follow-up about what happened at Eddington Hospital. Heads must roll. And I'm expecting to get a report in the next 2 days. Then if you do not get a joy from the district health manager, I'm gonna give you the contact numbers of Dr. Jacobs. Dr. Jacobs is a lead investigator in the Office of Health Ombudsman. That needs to go there. From there, you know the contact numbers of Section 27, a law firm. We need to take legal steps now. I'm tired of listening to these things. We need to sue those people who did that. We need to see heads rolling. Mzamu, there is uComrade uNedrex, uNedredlocks, who is about to be punished in 2 weeks by that person that we do not know in that facility. Before we leave here, you need to get the contact numbers, Comrade, Utibana notice manager, not only him, but all other people who are going to be punished by that faceless person. We need to see heads rolling. I cannot sit here and listen to all this. I cannot. And I'm expecting you, Mzamo, before we meet with Dr. Shabalal, to tell me what has happened about the person who continuously ill-treat people in a public health facility that he or she does not own. If it means that person must be dismissed, let the person be dismissed. But if nothing is happening, we must escalate that matter to the Office of Health Ombudsman and to Section 27 so that we can take legal steps now. I'm tired. I am tired, serious. And as well as my brother. My brother, when I am having a meeting tomorrow in Pietermaritzburg, I want you to call him. I cannot be sitting here listening to all of this. Because soon I'm going to run crazy. Because one thing that I know about myself, this is not about me. You know, Mzam, I was once accused in 2015, coming from Cape Town to Free State in a flight. I was sitting next to a white lady. Apparently, she misplaced her cell phone. But because I was black, by being black, it meant that I'm capable of committing a crime. Fortunately, I had only one bag. She came to me with police and said, I have stolen her phone. I gave them my bag and the jacket that I was wearing. They could not find a phone. And there were about many people there. You know what I did? I undressed. I took all my clothes. To make it easy for them. Che Guevara says, in order for us to get what we want as the oppressed and exploited people, it needs a certain level of madness. We need to be mad now. We need to be mad. Personal. If I can be discriminated, I will undress inside the clinic so that I can send a clear message. We need to be sending a clear message now. We cannot be begging for what is constitutionally ours. We cannot. I cannot tolerate that. We need a certain level of madness now so that we name and shame these people. In this country, we've got what is called Matupile principle. When we go to these facilities, some of them, they do not wear name tags so that we cannot name and shame them. Is that a standard operating procedure? No. What is happening about that? Because when we come and tell these stories, there is nothing we can do because you do not name and shame the person. How am I going to know this person if they are not wearing a name tag? Now, I'm name tags, but when you go to the facility, we do not see that. We need to be angry now as the community. If now where I stay in Konobushe, in Utinake, and I use Letitia Palm Day Hospital, I don't go there as a boss, I go there as a community member. But one thing that I do not tolerate is to see a healthcare worker ill-treating umpagat. Even if it does not come to me, I stand up and bang the tables. And we need to do that. We need to make sure that we share the contact numbers of district health managers with the community, as about MEC, as about HOD. So that when these things are happening inside the facility, we are able to call them and say, this is happening now. In Nelson Mandela Metro, I requested a meeting with the district manager. She walked out and said she's got an important meeting. I told her that meeting is important but not urgent. Why? The reason we came here is based on urgent matters. She walked out. I told TAC comrades that, she's going to come back. We went to the boardroom. We occupied the boardroom. They were about to have a management meeting. I told them that your manager said we must wait for her here. As to say where you're going to have your meeting, I do not know. Immediately, I called Aaron Mutwalet. He was about to start a cabinet meeting. I told him, Minister, there is this and this which happened here. And the next door is SAPC. You've got two options. You call the HOD in the province and the MEC, you tell them that DA must come to this meeting. Or else, I'm going to instruct all TAC branches to get taxis. We come and occupy this office. And the next door, there is SAPC. We need to use a certain level of madness in order for our cries to be listened to. But that level of madness does not mean we must destroy state property or harm anyone. But let's name and shame, let's expose them. Let's assist the government to get rid of all these rotten potatoes from the system. And all people who are ill-treating our people. And I cannot be sitting here listening to people who are crying as if nothing is happening. I cannot. And we cannot accept that. This is not a place where we must cry. This is a place, in my view, where we are supposed to say there is improvement. But if improvement is not happening, we need to change the key. The recommendations are as follows. The Department of Health should ensure that all clinical and non-clinical staff, including security guards and the cleaners across public health facilities, are sensitized on provision of key population friendly services to ensure a welcoming and safe environment for all key populations at all times. Key populations must be involved in the implementation of these training modules. Any reports of poor staff attitude, privacy violation, verbal or physical abuse or harassment, and or of service being restricted or refused should be urgently investigated. The Department of Health and PEPFAR should expand the Centers of Excellence model to ensure that at least 2 public health facilities per population in eThekwini serve as key population designated service delivery centers. A minimum package of services should be made available at these facilities as outlined in this State of Health report. Easy referral and adequate resources, including transport or money for transport, must be provided for people to take up these services. PEPFAR must support these facilities with additional key population-friendly staff and the resources to provide comprehensive health services to the specific key population being served. Ensure that HIV prevention tools, including lubricant, external and internal condoms, PrEP, and PEP are made easily available at all public health facilities. Make available external and internal condoms as well as lubricant in a range of spaces across the facility. For an example, waiting areas, toilets, gate, pharmacy, consultation rooms, quiet areas, out of sight, so people can freely and easily collect them. Ensure that PrEP is offered to everyone, including key population who are not living with HIV or test negative for HIV, with information shared on its benefits. Ensure that all facilities provide gender-affirming services, including using trans people's correct names and pronouns, providing a gender-neutral toilet for trans people, respectfully asking trans people which color folder they are more comfortable using, pink, blue, white, ensuring that trans women are not made to use men's corners, maintaining privacy and confidentiality. Additional healthcare workers and clinic staff should not be called into consultation rooms under the guise of helping, when often this is to mock and judge trans people. But also, I think, as we are moving to the next issue of index testing, I'm not scared, Mzamu, to tell you that I'm a born-again Christian, but a liberated one. When a preacher man is preaching there and his message is violating the rights of the people, I am a rebel by nature. I raise my hand and tell you, Pastor Kuti, what you are telling the people is a violation of the rights of the people and the Constitution. Even now, in what is happening in Palestine and Israel, I side with Palestine, because I cannot accept the violation of the human rights and the murder of people who are hospitalized. We need to stand against the system, Bapat. We need to challenge the system now, because we cannot allow a situation where the rights of the people are violated, where people are murdered under a false pretense of saying, I'm a Christian or I believe in this and this. If in our country we see that there are laws which are unjust, we must fight them. Like Section 12 of the Gatherings Act. That Section 12 must be scrapped off from the Constitution, because it is an unjust law which was used by the apartheid government to stop black people from organizing and mobilizing. That's why we need to challenge that and call for the amendment of the Constitution of our country. We cannot sit down and accept mediocrity happening at our presence. What are we going to report about when we go to heaven? What are we going to say to God? Are we going to say to God, we watched your people dying and folded arms, or we stood with your people? We need to side with the people. Thank you.
The next group of issues are on index testing. 100% of facilities monitored by Ritshidze engage in index testing. And of 1,775 people living with HIV interviewed, 88% said a healthcare worker had asked them for the names and contact information of their partners to test them for HIV. In terms of consent, 88% reported that they were allowed to refuse to give the names of their partners. While index testing has the ability to help identify individuals who may have been exposed to HIV earlier, it must be implemented in ways that do not cause harm to individuals or undermine their rights to consent, privacy, safety, and confidentiality. 41 sites had perfect scores, with 100% of people reporting that staff told them they could refuse to take index testing. However, at some, very few people knew they could refuse, as shown in the table. Index testing must always be completely voluntary. Only 87% of facilities say they screen for intimate partner violence as part of their index testing protocol. Of 1,782 people living with HIV, 91% reported that they were asked about the risk of violence from their partners. All facilities must screen people for intimate partner violence in order to avoid violating people's safety. Of those who do screen, 50% still contact all partners regardless. There is no point to the IPV screen if contacts are just notified of their exposure anyway. 8 facilities had 80% or less of people reporting being screened for intimate partner violence, including only 14% of people in Verolem Clinic and Tongat CHC. There must always be an intimate partner violence screen to protect people's safety who undergo index testing. Most sites said that if people living with HIV screen positive for intimate partner violence, they offer them services either on site at 73% of sites and or by referral at 45% of sites. All facilities should be able to provide on-site or referred services for intimate partner violence. Screening for intimate partner violence without adequate IPV services to respond to an individual's positive screen is dangerous and unethical. Referrals must be actively tracked to ensure individuals access them, and referral sites have adequate capacity to provide services to the individual. We will move straight to recommendations on this one.
Thank you. So the recommendations are as follows. The Department of Health and Health System Trust should follow all protocols outlined in the National Department of Health guidelines on index testing, including that index testing is always voluntary. All health care providers ask if the individual's partner have never been violent. Sibangumsindo manje, we're disturbing each other. All healthcare providers ask if all healthcare providers ask if individuals' partners have ever been violent and record the answer to this question before conducting their sexual partners. No contacts who have ever been violent or are at the risk of being violent are ever be contacted. Adequate intimate partner violence services available at facility or by referral. Referrals are actively tracked to ensure individuals access them, and referral sites have adequate capacity to provide services to the individual. All adverse events are monitored through a proactive adverse event monitoring system capable of identifying and providing services to individuals harmed by index testing. Comment boxes and other passive systems are necessary but inadequate. After conducting the conduct, healthcare providers must follow up with the individual after a reasonable period of 1 to 2 months to assess whether there were any adverse events, including but not limited to violence, disclosure of HIV status, dissolution of the relationship, loss of housing or loss of financial support, and refer them to the IPV centers or other support services if the answer is yes. Data on such occurrences must be shared. Carry out an investigation into all Department of Health and district support partner staff carrying out index testing to assess the implementation of index testing. The findings of this investigation should be shared transparently. Suspend index testing in poorly performed sites until it can be carried out safely with consent.
The next set of issues are on infrastructure and clinic conditions. The country's load shedding crisis negatively impacts the provision of healthcare in our clinics and can often lead to people waiting much longer to collect medicines or consult with a clinician. In eThekwini, the most common challenges include data capturers not being able to capture information, creating a backlog, and impacting follow-up with people who have missed appointments and other recall systems, and delays in finding files when filing rooms are in darkness. Generators at each facility could resolve these challenges, yet only 33% of facilities reported having a generator that is working and has fuel. 76% of facilities monitored in eThekwini were observed to be in a good condition, with little change from 78% last year. The most common reasons for poor clinic conditions were due to buildings being old and in need of renovations. %78% of facilities reported needing more space, with waiting space, rooms for private HIV testing and counseling, filing space, storage, and rooms for medical care, given as the most common things facilities needed extra space for, impacting negatively on congestion, TB infection control, waiting times, and privacy. On overall cleanliness, 73% of public healthcare users reported that facilities were very clean or clean, while only 1% reported that facilities were very dirty or dirty. We have our best and worst performing sites outlined in the table shown. And we have Molweni Clinic at the top, which is the best performing facility. And then we have Isipinge Clinic and Hlengisizwe CHC as being the worst performing sites. %45% of Ritshidze observations found that toilets were in a bad condition, with no soap and toilets being out of order, given as the most common reasons. And now we move to our recommendations.
Thank you. I think as a Ritshidze now, in this work that we are doing, at some point we need to reward the best performing facilities on these key performance indicators, so that we do not look as people who are negative. If this particular facility is doing well on waiting time or staff attitude and all that stuff, I think we need to reward them and make it public. By doing so, also, I think it will force other facilities that are underperforming to pull up the socks in order for them to be on the same level with those that are doing well. I think we need to do that, so that on our side, we are not seen as people who are only looking for faults, but where good work is being done, we applaud them, and us applauding them, we are not doing it privately, but we're doing it publicly. Recommendations are as follows. The Department of Health should ensure that all public health facilities have a functional generator like we have outside. Functional generator with sufficient fuel, with sufficient fuel and rechargeable bulbs, so that health services and administrative work can continue during load shedding. Ensure that all public health care users are consulted, tested, and or cancelled in private rooms. Carry out an audit of all facilities to assess infrastructural challenges, after which the department should develop a plan in order to renovate buildings and ensure adequate space to provide efficient, private, and safe healthcare services. The department must publish the audit results. In the interim, provide temporary structures and ensure that more people living with HIV are being decanted out of the facility and receiving longer ART refills to reduce the burden on overcrowded clinics. Ensure that all facilities are maintained to the highest standards of cleanliness, including through implementing regular cleaning rotas. Ensure clinics have resources to provide soap and toilet paper in all toilets.
The next group of issues are those on TB infection control. In South Africa, around 300,000 people develop tuberculosis every year, and about 56,000 people die. Yet TB infection control in our public health facilities remains inadequate. By following a simple checklist of good practice, including key measures that were implemented during the times of COVID-19, facilities can be safer for public healthcare users and staff. With the checklist in mind, Ritshidze has developed a scorecard and a traffic light system to raise the clinics on how good they are in TB infection control. Clinics that adhere to all these measures are given a green light. Those that are right track but still off the target, they are given a yellow light. And those that are red lights, the red light is given to those that are way off the mark on ticking the checklist on the 6 measures. In July and August of 2023, only 1 facility was awarded a green light status for checking all 6 measures of the scorecard. 48 facilities were awarded a yellow status for following about half of the best practice measures for infection control of TB. 17 facilities surveyed failed altogether to meet these 6 basic practices to stop the spread of TB. Now we are going to move on to the recorded stories.
Currently, I'm using Newlands West Clinic. It was so painful. We went and tested umntwana for TB. Ngebhadi watholakala ukuthi positive ama-sputums wakhe wayiqala treatment. On the 2nd month, mase ngiyolandela umntwana medication yakhe. Ngafika around 12. Unesi wangitshela ukuthi abantu be-TB bafika ekuseni, you can't just come in, ngeke akwazi ukungisiza. Into engambuza ukuthi how come ukuthi ningasitsheli while sizolanda medication ukuthi kufanele sifike early if sizothatha medication. So wangitshela ukuthi yena ngeke akwazi ukungisiza. Luckily bakhona onesi engibaziyo, ngahamba ngayofuna usister in charge ukuthi akangi-assist because angikwazi ukuphindela emumva sengifikile kwi-facility. Ngamtshela usister in charge ukuthi ngiyile ku-sister, wangitshela ukuthi ngeke akwazi ukungisiza because ngifike ngalesikhathi. So usister in charge waya kuyena bakhuluma. Wathi usister in charge, okay, akangikhiphele ikhadi. Wathi usister nje ngeke akwazi ukungibhekela ikhadi because lelo khadi akalazi nalokuthi likuphi. Into ebuhlungu ukuthi amakhadi ahlala khona kuleyo room leyo. I end up going back to sister in charge. Ngamtshela ukuthi uthenge akwazi ukungibhekela ikhadi. Where's sister in charge wang-assista, walikhipha ikhadi, wanginikeza medication. And it's so painful ukuthi ungafika kwi-facility ugcina uhambile ungalitholanga usizo. I would like them to change attitude towards patients because ekugcineni kosuku usuku ungazile ukuzodlala mawuze clinic, usuku wazi ukuthi uzokwenzani. And into engicela ukuthi kuyenzeke leyo ukuthi ama-patient mayifikile ukuthi alinde eminyango. It's so painful, kuyabanda manje. And even ngisho ngathiwa kuyanetha bahlala eminyango. I would like them ukuthi kubuyele kulesa simo before ukuthi mabefika bangene ngaphakathi. Because since kade kuno COVID manje sebehlaliswa ngaphandle abantu. Ngisho ngathi ufike early as possible, but kufanele udliwe amakhaza ngakwenzeki ngebhadi. Ufika nje ubanikeza ikhadi and uthathe medication yakho uhambe, awu screen for anything. It's just that ukuthi bathathe ikhadi lakho bawukhiphele ifile yakho and go inside the clinic. Uthathe medication phuma uhambe. Intaba effective kuyona ukuvula ama-window and doors kuyavulwa ke lokho, but in terms of ukuthi umuntu mayikhwehlela kufanele bam-fast track, no, uyahlala nje ukhwehlele until kuze kube ukuthi kufike egameni lakho bakwenzeke whatever uzokuzela.
Bengisebenzisa le clinic yala Imilens West. So experience yami iTB ngayithola last year is about September, if I'm not mistaken. Isifuba sami ngingasizwa ngitsho singiphethwe umkhuhlane. Base ngezwe umkhuhlane awupheli, isifuba siyasinda. Then mesiyo checka wathatha isikhathi eside kunalokho ebesike expectine noma ngoba nama results sasitsho sibazowasenda efonini sayihamba sayoyicheckela thina. Ngoba sasitsho sihlambe ama results asathu 4 days ukuthi efike i-message yemphumela, but saze kwaze kwaphela 2 weeks noma
2 weeks, yeah.
2 weeks.
2 to 3 weeks.
Banginikeza amaphilisi. Then lapho ngaqala ngilokho ngiattenda khona. Ngilokho ngiattenda but isikhathi lapha ngasho ukuthi abakwazi ukusigcina. Isikhathi ngoba sometimes bemele ngihambe ngiyolanda treatment mase ngeschooling. Mengiyeschooling sometimes bengize ngifike later ngenxa yakhona ukuthi isikhathi abasigcina bagcina benaka abanye thina bengasinakile. Bagcina beze bebona ukuthi ngigqoke uniform ukuze kuyima bengi-attend. Mostly ngoba la i-area ngiba kuyona ila ka TB ngoba nami bengize sometimes ngifike after break esikoleni noma ngifike ngebreak. But la amanye ama-period angisakwazanga ukwakhetha ngenxa yokuthini bekumele ngiyolanda i-medication. Istaff nje siba harsh too much. Sometimes abakwazi uku-understand thina. Ngoba nathi hayi ukuthi mhlambe nathi sesiba disrespect noma khona la singababoni khona sayibona ivalue yabo. Kuyikona ukuthi nathi ukuze sibahloniphe nasi sicela besihloniphe.
Okay, ngangisekliniki ngiyolanda amaphilisi imishanguzo yami. So ngahlangabezana nenkinga yokuthi imishanguzo yami bengiyidla kahle. So ngithe mengiyidla ngase ngiba nenkinga yokuthi sengitholakala ngidiabetes.
I went to the clinic to collect my medication, and I was taking the medication well, and then one day I experienced that I had a problem. I was now diagnosed that I am diabetic.
Emva kalokho mengitholakala ngidiabetes kwase kuba nenkinga yokuthi mangilanda amaphilisi ashukela fanele ngicela ukuthi ngicela banginike i-date yodwa ngoba angikwazi ukulanda namhlanje amaphilisi ngiphinde ngiyolanda amanye kusasa iyangqilaza leyo nto.
So I then asked that when I come for my medication collection, that they should make it one day. When I come for my diabetic medication and other chronic medication, that I should collect them at the same day.
Ngithe mengiphindela ngilanda ngolanda amaphilisi ngafika ngabatshela ukuthi amaphilisi abanginika wona kashukela awangiphathi kahle. Base wangishintsha udokotela wanginika amanye nala amanye angangiphatha kahle.
I then told the doctor that the medication that I'm getting for diabetics is not treating me well, and they changed the medication. Still, that one was not treating me well either.
Bangishintsha futhi kwamanye abaza bo3. Uthe lawo wesithathu hayi asengiphatha kahle ke wona. Ngabuya ngabatshela ukuthi hayi lawa a-right for me.
So until I was given the third medication, variety, and then that one is treating me well up until today.
Ngabuya ngeza ku-sister ke ngathi ngiyacela bangichazele ukuthi njengoba ngidla amaphilisi la maphilisi engiwadlayo okay ngifuna understanding manje ukuthi ushukela wami kuthiwa uyehla kuthiwa uyanyuka uwehla makunjani unyuka makunjani.
I then asked the sister to explain that when my diabetic rate goes high and it goes down, what is the cause of that? What causes that to happen?
Emva kaloko hayi abakwazanga ukungichazela ngaze ngathola nje omunye udoctor engamcela ukuthi ngicela angisize ngoba manje nginenkinga njengoba nginoshukela angizazi ukuthi ngiwa makunjani ngiba kwesikhathi ushukela uqala ezandleni mawuqala ezandleni ngiye ngitshe ukuthi inkwantshu kanti kuthiwa kufe kwama symptoms ashukela ashoyo ukuthi usuya drop asho ukuthi kufanele uthathe something uhlafune.
So up until today, I don't know what causes that. I have tickling fingers on my tickly feeling on my fingers, and that is a sign that I've been told that it shows that my sugar level has gone down.
So emva kaloko ke saxabana ke no sister owayezolekela udokotela ukuthi bangichazele ukuthi ene ushukela uma wehla kusekuyini inkinga uma unyuka kusekuyini inkinga. So wathi usister ene yindaba ngiyobuza udokotela lonto ngoba efanele ngibuze bona. Ngathi mina into engizothi ngibuze udokotela ngoba vele ubenganayo ikheme engikhuluma nabe vele angibhekisele ngoba nangisikhathi ngishintsha treatment ubengangiphathi kahle yikho ngicele udokotela ukuthi akangichazele.
So then I asked the doctor to explain, and the doctor explained what causes my sugar level to go up and down. And when she explained to me, I was happy with the explanation. But the sister asked, why did I have to ask the doctor and not her, for her to explain why my sugar level is going up and down? And I told her it's because of the treatment that she gave me, or the attitude she gave me when I was asking her what causes my sugar level to go up and down.
Ngaba nenkinga ke no sister ke saxabana ngoba manje shuthi mina sengazi ngaphezulu kwakhe and ngifuna negama lamaphilisi lawe engiwadlayo kashukela ukuthi yini amagama ngoba ahlukene.
So then after that, I had a problem with the sister. Every time when I go to the clinic, she has an attitude towards me because she says I know too much and I communicate with the doctors. So when I ask for the name of my pills that I'm taking, she doesn't give it to me.
Imishanguzo namaphilisi ashukela uma sengidla kanye kanye kwase kunginika inkinga kwase kugulisa kakhulu naloko bekuyikona.
So another problem I had is that when I take my chronic medication and my diabetic medication, it clashes and gives me a problem.
So ngase ngabuza ke kona ukuthi yipi indlela engangisiza ngoba manje iyangilimaza lento ngiyayibona. So wangilekelela kudokotela wangitshela ukuthi no uma ngabe udle umshanguzo qala ngawo ulindi hour mase kuyima uphinde udla la kashukela uzoba right.
Then the doctor was able to explain to me that I should not take my medication at the same time, but I should take them different between, give them an hour allowance between each other.
Emva kalokho ngitheme ngibuya sengizolanda amaphilisi usister shuthi esayibona ukuthi angisakhuluma kakhulu nabo sengifuna ukukhuluma no doctor. So wangitshela ukuthi nje mina ngitshela kakhulu ngitshela ukuthi ngiyazi nokuthi ngangibatshela ukuthi lento eniyenzayo siyawazi ama right ayi ukuthi ahasuka la ayaphi. Emva kalokho wangiphindisa back emaphilisini okuqala la wayengihlukumeza.
So then, since I was communicating with the doctor, the sister stated that I know too much, and then when she gave me medication, she gave me the first regimen of medication that was not helping me, and that was giving me a problem. So after I communicated with the doctor that I need to be sent back to the medication that he has prescribed for me because the first one was not working for me, it was giving me problems, and then we had a very big clash with the nurse, and then I stopped taking my diabetic medication. So I'm now treating my diabetic with drinking water. Thank you. I live in a Mashu. I'm using Polyclinic. I went to Polyclinic having a flu, and I asked the nurse, since I have a flu, which room should I go to? So she told me that I should go leave sputums at the room where the sputums are taken. So then I left my sputums, and she told me that she's going to call me after the week when my results come back. She didn't call me until I went back to Poly to check for my result. So when I get there, I told that I had TB, I had to start treatment.
ngiyithathe treatment ye-TB athi ngizoyidla le treatment le inyanga yonke
So I took that medication. I was told that I'm going to take it for a whole month.
mase sengibuya siphelile inyanga ngimtshela unesi ukuthi ngicela ukuthi angi-check-e futhi okwesibili ukuthi i-process yami ihamba kanjani athi angihambise iyikhwehlela futhi laphaya khona la ikhandiswa khona iyikhwehlela.
So when I went back to the clinic, I asked the nurse to check that how's my progress when I'm taking this medication. She said I should take sputums again.
aphinda anginika amanye amaphilisi futhi ngigoduke na ngoba wathi kuzothatha u-6 months.
And then she gave me other medication that I should take, and she told me this time I'm going to take them for 6 months.
ngithe sengibuya ngambuza ukuthi athini ama-results nesi
When I went back, I asked for the results,
athi unesi hayi wengane awunalutho wena
and the nurse told me that I had nothing. I had no TB.
awunathiphi ngimbuzi nesiphola le medication ade ningidlisa yona ngikuthathela ninginike into engamele ngidle mekuthiwa ngiyagula manje iyangigulisa ngoba phela imizimba yethu ayifani ngenze njani.
So I asked her, since you're telling me that I do not have TB, the medication that you are giving me, why was I given this medication? Why was I prescribed the wrong medication for me to take since I do not have TB? What if this medication causes problem in my body because our bodies are not the same and they do not react the same way to medication?
athi unesi yena akahlangana akayenelepi akahlangani nelepi.
So she told me that it's none of her business. She's not a lab-tician. She doesn't go to the lab, and she does not make medication.
into engamtshena yona kunesi ngamtshela ukuthi cela afunde ukukhuluma ngoba akalali ekliniki.
I told the nurse that she must have a way to speak to us as patient because she does not sleep at the clinic.
Yebo ingagoduka-ke ngaye ekhaya ngamtshela futhi ukuthi mekuwukuthi ngiba nenkinga ngiyagula njengoba ningidlise i-medication e-wrong ngizobuya ngizonibopha lapha wathi nakanendaba ngathi uzoba nendaba-ke ngalolo suku ngoba mina ngizobe sengidla ngibhekene nawe.
So I told them, since you guys gave me medication to take and I had not had TB, if I have a problem, I'm going to come back to the facility and sue you. And the nurse said that she doesn't care and she doesn't have a problem with that. Thank you.
Thank you, comrades. Smen Makaban, sesophuma manje. Before we go to recommendations, Comrade Simpio and Comrade Humzam, umphathi wethu sethu la yabo umama lo diabetes who was forced to stop taking it because of attitude no sisi lowa I think masiba ede kwaba sizobahlangisa nomama in order for inkinga zabo zexazululeke with immediate effect. 2, according to this report bakuthi the section that talks about TB iyasitshela ukuthi apha eNingizimu Africa 56,000 people are dying of TB a year according to the World Health Organization report. And out of that 56,000 about 33,000 of them are people living with HIV. What does that 56,000 tells us? You take that 56,000 sangqola klakon ingapha inama CHWs bangumsindo phatha abantu babangumsindo next to you. The 56,000 deaths of TB, you divide them by 365 days. It tells us ukuthi a day in South Africa more than 153 people are dying a day. And on that 153, more than 120 people who are living with HIV are dying every day. Therefore, we know what are the reasons. If you are living with HIV and you are not initiated on treatment in time, your immune system becomes compromised and you become vulnerable to a lot of illnesses. It therefore means We cannot separate the struggle of access to HIV treatment to a struggle of ensuring that we improve TB services. The available and effective TB drugs are still expensive. Companies like Johnson & Johnson are still continuing to make profit out of our lives as poor people. If we were able to force pharmaceutical companies to reduce the prices of ARVs and also put them under pressure to apply TRIPS flexibilities in order for us to be able to get effective TB drugs, we need to apply same strategies. And if not, many people are going to die of TB in South Africa, as if TB is not curable. It is curable, but the problem that we have, the TB medication that we have in the country now, the course is very long and tiring. And there are effective TB medicines, but the problem, they are still expensive for poor people. And we need to make sure that we put pressure to pharmaceutical companies, including to our government, because the Department of Trade and Industry has not yet enacted the intellectual property right and policy since about 6, if not 8 years ago, and we need to put more pressure so that we can be able to make sure that we bring an end to a monopoly of our patent laws and these pharmaceutical companies to continue making profit out of our lives. We need to put more pressure. If it means we must take it to the streets, we must take it to the DTI in order for this process to speed up, let it be, because at the end, we are about saving the lives of the people. So the recommendations are as follows. The Department of Health should issue a communication to all facilities stating that all windows must be kept open. TB infection control posters must be displayed in visible places in the waiting area. Public healthcare users must be screened for TB symptoms upon arrival, like we did during COVID. If you go to the bank or wherever, you were screened. But when we go to our clinics, we are not screened for TB. And it shows that our government continues to make COVID as a priority as compared to other sicknesses. People coughing or with TB symptoms must be seen first to reduce the risk of transmission. People coughing or with TB symptoms must be provided with masks. People who are coughing must be separated from those who are not while waiting. Carry out a full audit of all public health facilities in the province to assess TB infection control based upon World Health Organization guidelines, after which the department should develop a plan based upon the infrastructural, human resource, or behavioral challenges found in order to improve TB infection control. The Department of Health must publish the audit results. So, we're moving to the next item now, before we close. We've got leaders from these organizations. I'm gonna give them 2 to 3 minutes. If I stand up, you must know, Uti, you are left with 3 minutes before you finish. After these leaders, we will give to each department to comment, and we are not going to tell the department what to say. And Health Systems Trust. So, Comrade Mabusi, Comrade Pumzile, Rev Ngobo, Tabani, please, 2 minutes minimum, maximum, 2 minutes, 30 seconds. So we will start with Comrade Pumzile, Mbambo from Napwa. The floor is yours, my lead.
Thank you, comrades. Ngiphinde ngibingelele maqabane. usengishilo wathi uphumzile mbambo ngiqhamuka efolweni. Akukuningi kakhulu ke ngoba isikhathi uzosukuma ucomrades. Ezunapha ucomrades uanele la oke washo indaba ye-COVID. I-COVID ivale yonke into unapha sidila kakhulu nama-support groups e-clinic. The most into eningi engizizwa ixoxa lana zisibuyisela back to form ama-support groups wonke ama-clinic as unapha ukuze abantu bakwazi ukuba full information and nobudlelwane bama-clinic. Ama-clinic lapha kwi-department ngicabanga ukuthi wonke kumele abe nawo ama-support group e-clinic. The most abanye ama-reports asike siwathole kwamanye ama-clinic kuthiwa iy'ndawo zokuhlanganela azikho. So kunento esike siyenzeke thina efolweni ungqongqoza nakubefundisi ngoba basali beyi-community basiphe iy'ndawo if benazo sikwazi ukuhlanganela. Bese kuba yilokhu okugcina mengicabanga kwisikhathi sami enginikwe sona esincane ema-clinic indaba yama-results abantu aba-HIV positive sike sibone sekubheka ama-securities ebheka ama-results abantu. So singacela nje kakhulu kwi-department ukuthi mhlampe babe nakho sinama-CCGs mhlampe kube yiwona asibhekela ama-results abantu bethu abasuke beze e-clinic. Ngiyabonga.
Siyabonga ngokheli. Hayi, that is leadership. Sizabiza ucomrade uMabuse Gwete from PWN but ke she's limping shows uzakhuluma lapha yana.
Ngiyalibonga ithuba ngiyawubingelela umhlangano uMabuse kaGwete u3 minutes engiphiwe wona mhlawumbe umuntu akasho ukuthi these stories are not unique and I am hoping ukuthi Department of Health ngeke ifocus kuphela kule reports ethulwa namhlanje kuma facilities amonitor uRitshidze but they are going to cut across kuwo wonke ama facility esinawo eKZN to address these issues ngoba zikhona yonke indawo. Number 1 lo. Number 2 mhlawumbe nokunye umuntu angakucelela bakithi abone sibethe emakliniki ikakhulukazi njengomuntu who has extra pulmonary TB right now ukuthi niba sensitize on how to manage us njengabantu abane TB abangayijwayele. Mina ngine TB yamathambo and unesi kuthi ngemonth 3 le ye intensive phase ye treatment yami athi angihambe ngiyokhwehlela ngine TB yamathambo angikhwehlelanga ukuze ngidagnaizwe. So unesi with respect we discussed that issue and wabona nayo ukuthi yazi ngempela kona but she did not know what to do with me ukuze phela ngiyocheckwa ukuthi I treatment iyasebenza yini. And from that day she never asked ukuthi what happened and nami ngiyazithulela ngibukela ngoba ngenhlanhla yami vele ngihamba isibedlela due to I complication ya TB itholwe late. So isibedlela sona they did ama bloods ECR and abonakala ukuthi I treatment iyasebenza. However a clinic there's no communication between isibedlela and the clinic ukuthi bazi ukuthi I treatment yami isebenza kanjani. And also uma ngabe nibasensitizer they will know ukuthi uma ngabe une TB efana neyami you are on treatment for 12 months. Babuza mina ukuthi utheni udokotela lapha ukuthi uzoyidla isikhathi esingakanani treatment. Ngiyashwa kudokotela wayenza iphutha eqaleni wathi 9 months and uneswa phala phansi 9 months kwathi ngo-October wathi ngikuphindisa esibedlela khona bezokdischarge. Uma ngifika esibedlela athi udokotela no iphutha 12 months. If unesi eclinic uyazi ukuthi fanele ngabe ungimanager kanjani that will have been helpful. Ngiyabacelela bakithi ukuthi nibasize extra pulmonary TB khona sinayo siplane egciwane lengculaza sinayo futhi nayo. Mhlawumbe ke uma sesikhuluma ngama attitudes engivala 3 minutes wami uphela. Mhlawumbe ngempela uhulumeni comrade wena anele ukuze si address le issue awukakwazi ukusinikeza ama health professionals athi awangayisebenzisi the same system abasebenza kuyo bona baya kwi private thina sisali njengabantu abaphuwa mhlambe ngelinye ilanga uma ngabe ngababuyisa ukuthi ayasebenziseni sonke phela ngoba iyafana siyolunga lapho comrade anele mhlambe lo umsindo kufanele siwenze sikhumule sibe nqunu sibacela ukuthi ababu medical aid ayiphela.
Sabonga. So sizawu hand over now to uRev Ngcobo. Over to you mfundisi.
Ngiyanibingelela. Ave ngakwazi ukukhuluma kancane ngoba ngijela ukushumayela. Siyabonga kakhulu i-report ethusayo. Kodwa ke mina ngi-represent i-organization ekuthiwa iSanarela. Abefundisi bamabandla ahlukene or not Christians only, just the religious sector, ukusupporta abantu abaphila noma aba-affected ezike nathi sonke si-affected. Into pick up njena ngoba sike kwathiwa sizoba ne-pick up point ebandleni lami la eMlazi eLuthela, but it didn't go anywhere leyo nto. Kanti into engasiza njengoba kushiwo nje, kodwa I think i-approach mhlawumbe uNational Health Systems Trust mhlawumbe mangase ayi-coordinate kahle leyo ndlela, ngoba makufika kuthiwa abantu kwi-chronic abathanda ukuyithatha esontweni, angiboni ukuthi kuseva kanjani the wider community. If few, if abaningi bekwi-medical aid vele bewalanda ka-clicks or beposelwa ukuthi if approach amabandla kanjalo, then i-community ngeke isizakale. Kanti for many things sinezindlu zesonto eziwu-7 la eMlazi, zi-spread out kahle nje, northerly, central and southern, engasetshenziswa as ama-pick-up points ukuze mhlawumbe silwe nale discrimination. Kodwa kumele ukuthi ku-organize ama-organizations aspecialize kuleyo nto, because thina as abefundisi asiwubona ama-expected logistics nani, but if you come and sit down with us nisho ukuthi lento mangabe nifuna ukusebenzisa leli sonto, how are you going to manage it? Singalalela ngenye indlela ngoba nathi we are members of the community, nathi we have family members yiyo yonke into kulomphakathi. So izindlu ezivalayo 5 days a week that could be used emphakathini ukusiza if ke abantu besi-coordinatela kahle, ngoba phela angeke sazi yonke into thina siyashumayela. Otherwise enye into engiyibonayo kuma-nurse bandla, uma wami was a very good nurse for good 30 years. I'm proud of that. Angakaze just athole i-complain ukuthi mhlambe no-nurse bayayidinga thina as abafundisa endaweni for clinical pastoral care. Nje sike sikhulume nabo ngoba siyakufundiswa nalokho ukuthi kukhulunywa kanjani neziguli, or mhlambe wena ke if you are also affected bese uya discriminate, ukhuluma sinalo lolo lwazi mhlambe ke bengas approach obano in charge bama facilities, awukuze uzokhuluma ne staff sami, you know, even about human rights and izinto ezinjalo nje ukuthi bahloniphe, ngoba ngenzeka ukuthi nabo ba burnt out, badinga support. They also need someone to listen to ukuthi nje indaba usowudelela kangaka kanti lolu bizo lwakho uyayibona into enjalo. Kodwa bengakhuluma kahle mhlambe nasi ke phela mhlambe bebona okhololo angazi bengaboni an ordinary community member mhlambe babe aggressive. Yilokho njena kuningi engakusho kodwa akunalutho ngoba siyazana sokukhuluma eceleni.
Siyabonga mfundisi. Eish, nangu size ngabizwanga. You will introduce yourself.
Sanibona. Kuthabana Mthembu, chairperson ka-Tech la eThekwini. Ngiphatheke kabi. Kufanele ngiqale nje lapha. Angazi uma sothi i-Department of Health le noma i-Department of ukuthi sife yini. But I know ukuthi nani ni ashamed ngezinto enisizwa la. TC uzobehlanganisa 25 years ngoDisemba. Silwa lempi. But still today sizozwa izinto ezinjengalezi. Shame to you, department. Shame to you. Asazi ufanele senze njani. Abantu bebeka izinto bekhala. I feel ipain yakho yawo. Just like how I feel it. Kubhlungu ngempela. Ngicabanga ukuthi fanele nishintshe. If kumele kufake uswazi B sonlekelela. Singama organization lesa staff esilapha ngeke bakwethu. Phela fana nokuthi manje yonke imisebenzi lo suwenziwe fana ukuthi awukho. Cabanga ukuthi thathani nibuyele emuva. Yanixolela, phatheke kabi kodwa. 25 years senza yonke lento. Ngiyabuya ngisakuthina ukuthi sizonicela ukuthi nibe khona kuma DCT la sohlala khona. Leadership yami ngapha sizohlangana. Kumele ngempela esibuyele emgwaqeni. kumele sibuyele emgwaqeni ulima enizoluzwa ilolo ngoba sibuyile sakwenza yonke lento sahlala saobheya sathi ngcono kuhlalwe kanjeni no ekufanele sibuyele emabranchini siwatshele uthi akiwe emgwaqeni bazozwa laba bantu visi yonke into ilunga ngaleyo nto but niyasibona ukuthi nenza into embi isenza abantu abangezwe yalithanda lelo ukuthi uma abantu bese clinic agula ingqondo bakwethu no agula ingqondo bawo mama singabazali singayonke into just ukuthi sofuna lokho oku right for thina wena sinikezeni khona kuphela comrade mzabalasi uyaqhubeka amandla.
Thank you, Chairperson. Thank you, Chairperson. As I'm going to call the next speaker, Utabang is reminding me in 2003, we Congress here, TAC, eThekwini. It was before 2004 elections. We said no treatment, no vote. Because as people living with HIV, we wanted to show the politicians Uguti, we do have the power. Utaban is reminding me of that. And we are in 2023, next year is 2024. 20 years down the line, we're still talking about the same things. I'm gonna call upon Sis Primrose Sitole from Health Systems Trust.
Beshilo ngu Primrose ngivela ka HST. Mhlambe nje okokuqala umuntu akabonge uhlelo olukanje enulihlelile ngoba ila esikwazi ukuyibona khona ukuthi njengoba sisebenza senza kanjani ikuphi futhi lapho esingenza kangcono khona. Siyabonga kakhulu ngereport sibonge futhi ukuthi kuyavela ukuthi zikhona indawo ezenza kahle. Akuyona yonke indawo lapho okuhamba kabi khona okusho ukuthi lapho esibona ukuthi akakwenzeki kahle kusasidinga ukuthi siyobukisisa ukuthi singenza kanjani ukuze umsebenzi wethu uncomeke. Ngibonga kakhulu ebebekhona bekhuluma ngama experiences abadlule kuona. One will say abantu balimele kakhulu and kuyasho ukuthi psychosocial uzodingakala because kubhlungu ukubona umuntu ekhuluma ebekhala that says ipain inkulu mukhulu umonakalo and I believe kusazomela sisebenzisane ukubona ukuthi silekelela kanjani kulabo abantu abalimele kangaka emoyeni ngenxa ye treatment abebeyithola kuma clinic. Kuzo zonke ama indicator abekhethiwe there were recommendations that were made abhekisiswe kakhulu ku HST sisebenza no DOH because okwethu ukulandela u DOH ama initiative abo ukuthi athini ebese thina siya support. So sithi njengoba senrecommendile we will go back and sit down sibukisise zonke izinto en10 yasicela ebese ke siyabuka way forward wakhona ukuthi uzothina. Bengitshela ukuthi kuzoqala umphathi akhulume because my part is to support umphathi into ayishilo ukuthi cha lokhu umphathi asekushilo kuzoba njalo kodwa ke kwaseqala mina siyabonga kakhulu.
Siyabonga mama. The reason sigcina ngomphathi is because we respect the protocol. We observe protocol. Over to you again, Mphathi.
Sanibonani. Bangibiza ngomama Masondo ke mabe ngibiza. Ngiyabonga awukhona ongishoyo ngale. Ngiyabonga kakhulu. Ngibonge yawa nethemba lakho. Abantwana esisebenza nabo ngokujwayelekile baka Ritshidze angibabonanga ngithema ngithi ngiyabachecka khona baningana ba 3 or 4 but i-team ayiphelele bathi bayasebenza somewhere. Ngiyabonga kakhulu sisebenza kahle nani. Ngihamba besifisa this time ukuthi ama facility managers abe khona ake singawanikeza feedback awakweze from the horse's mouth mhlambe kwenza umehluko ngoba last time ngicabanga ngangingedwa abantu mawubatshela into njengale bathi usesukile kuMasondo nje Uyabona? Kanti uma bekhona bayayizwela batshode nabo njengoba nami ngitshotile nje. Uyabona? Mhlambe lokho kuyosiza ukuthi uma begoduka nabo kuloko esikuzamayo bayoyicabangisisa kahle lento yokuthi ama clinic kumele ke akashintshe unyawo. Hayi ngoba kungekho okuzanywayo njengamanje. Sibonge kubo bonke abathatha ithuba bazositshela sampling le isample kuningi engicabanga ukuthi kuyenzeka kuma facilities ethu okungaphumeleli ukufika kanje kule platform. Siyabonga kakhulu ningapheli umoya. Ngihamba no Mrs Mdluli omele iSouth Service Area umlazi namaphethelo kanye nephakathi neCentral yeTheku bese ngihamba no Mrs Mkhize omele iWest kanye neNorth okwanamhlanje ngoba is manager ebezikade zimenyiwe la sihlukane phakathi ngoba kunamanye ama-agent matters ekufanele zwa attend but ngokuzayo ngiyathemba yawa kuzoba khona okuzayo ngizwe ngathi ukhathele akukhathalwa uma kukhulunywa ngempilo thina siwumnyango wezempilo Mthembu hayi umnyango wokufa. Hawu kukhona nomunye ubhuti engimfanisa engambona ngapha eGoli kwi key population meeting workshop ngibona nje akanginakile ngiyathemba kangidinelo. But anyway ke asibuyele ku serious business of the day. Ngizocela uthe uyawa esho ethi ubhuti wase Hammersdale ono dental problem nabanye njalo njalo bese ngiyithumelile imiyalezo kwabasendlini ukuthi ngicela bangithathele lamagama kanye nama facilities abo. So ngizocela ke masukuma la khona no Theuyopha khona no okhuluma indaba yase Eddington no sifo sikashukela nabanye ke njalo njalo mhlambe ngibamisishile ekubabhaleni ngicela babonane no Mrs Mkhize kanye no Mrs Bay sithathe lama details khona so exchange this before end of business akulali umuntu ngingalele. Sizwile somnyango wezempilo uya uzobekezela angangibaleli mina isikhathi. Kukhulunywe lana ama issues amaningi are related to staff attitude kanye nama long waiting times. I department nasiwumnyango wezempilo siya observe lokhu sikubheke njenge district after each and every quarter ukuthi ama facilities each and every month athini ngalokho siwagreel ukuthi ama reasons of deviation athini and what are they planning going forward. Mhlambe ke lokho esiqalile akakabi effective kodwa siyakumonitor. It is not acceptable by umnyango wezempilo. We are not standing for that umnyango wezempilo. We standing for a lot of better reasons. So angizoqhubeka kakhulu kuloko sizohamba siyo reinforce ne managers ama facilities kuwo wonke ama platforms esihlangana kuona. Uma ungabheka la uWhatsApp wami kune platform esihlangana kuyona ne manager usubovu and red ngikhuluma yona lento. Uthe umese simdlula isifika sikhuluma nje sikhuluma into yokuthi kukhona aba playful emsebenzini abangawuthathi serious kanje. Hayi ukhulumile yena ngoba bengingafuni phela sihambe ngathi asizwene emotweni. Ngisho kithi nayo nami ngiplayful nje ngoba phela sisuke singaxabene emsebenzini angithi hayi wena base kufanele kusetshenzwe kuyashintsha ukudla eplateini. Sengikade ke mina ngiqalile ukukushintshisa ukudla eplateini la ngihleli la kulo WhatsApp ukuthi abantu abanyakaze la bekhona but we will do a follow up and make sure ukuthi what we have spoke about here luba khona ushintsho nyana. Kusithokozisileke ukuthi thina sasilana last year ne report ekhona la hey last year was terrible. Call this terrible umuthanda but last year was really kwakungazuthi ngizophuma igazi ngigoduka ngekhaya ngendlela okwakubhlungu ngayo. Angisho ukuthi loku okupresentelwa ngithi kungcono cha kungcono kancane. Engikuthokozelayo ukuthi kuma facilities ayemenyeziwe la ngonyaka odlule improve amanye sekuwe amanye kusho ukuthi it's a question of sustainability throughout i-district yethu that is very vast enkulu kunawo wonke kwi-province. Kukhona ke esikwenzayo uma ngabe ninotisile kuma first 2 slides nje sisandokuqala bekukhulunywa umubukile okuningi i-staffing siyinkinga kakhulu kuma klinika kamasipala. Abebovu abamaningi wonke kuleso slide kodwa ke si aware of logo and kukhona okwenziwayo ngakho. Number 1, i-department iyawathatha is planning of taking ama clinic back. We have started in the previous financial year sathatha iketomena ebikade inomasipala no province kwi-site eyodwa. Kulonyaka si plane ukuthatha u7 sizowathatha kusho ukuthi end of financial year sizoloku siwathatha nje siwathatha ngoba ngeke ngamuzwa uchairperson ekhuluma indaba ukuthi iminyango yonke kahulumeni iya-strugglisha in terms of money. Awuveli nje uyithatha iklinikhi engathi uthatha indisho isusa la uyibeke la. Kunezinto eziningi ekumele zenzeke very safely. So silandela leyo mqathango ke kanye nokuthi uma sesiwathathile government sokwazi yini ukuthi si ready yini ukuthi asebenze ngendlela. So ke ngisho lokho ukuthi kukhona esikwenzayo si aware ukuthi sesihambile isikhathi eside but we have started siwumnyango ukuthi siyilungise leyo nto ngokuthi sibheke ukuthi what could be best for ama communities eThekwini. Okwesibili esiphezukwa nje kulo leli sonto besingakawazi ke nomhlangano ka Ritshidze ukuthi uzoqhamuka lana angiphenduli ngoba sengizwe nithi silungisa into yokuthi iaccess ama services afike kubantu. Ama-clinic angithi sendishilo nathi ayagcwala futhi enza kancane futhi angazi kunjani angithi kwaba khona iprocess ekwakuthiwa u-PhD re-engineering la ekufanele khona ama-services siwathathe siwase kubantu. Kusho uhulumeni wabantu angithi uthi ama-services abantu asiwa sekubona ngoba baney'ngqinamba ey'ningi ezinjengokuthi akanayo imali yokugibela kabili kathathu aze ufuna iklinikhi. Samepha wasinikeza amabhasi uhulumeni samepha savula ama-mobile clinics kwaqhutshekwa lapho kwaba khona ama-outreach teams ukuthi into ewu-health service ayitholakale nje kalula umuntu angastrugglishi ngaleyo ndlela. Sesiplaneke ukuthi ngoba umasipala ushoda kangaka njengaphakathi ingoba nabo bayalandela lowo mqathango ukuthi abavula ama-mobile services. Istaff asikho bathatha istaff esingaphakathi siye kulama mobile services. Umuntu oye eklinikhi angakutholi joy ahlale kakhulu baze bakhathale badelele mhlambe ba burnt out ushilo umfundisi. So ke sikuleyo process yokuthi thina siwumnyango ke wezempilo singabasiza kanjani ekutheni si remap sithathe lama mobile esinawo akabheke nalama points akade rana umasipala abahlengikazi nabasebenzi abasebenza kulama point babuyele ngaphakathi ke kube ne-improvement. Kukhona okuncane sikuzamayo. Kukhona ke into ye-staffing ikhona into eke yakhuluma ngama-COVID nurses lana ngenkathi kune-COVID uhulumeni wasiqashela ama-nurse about 2100 eThekwini ezolekelela kwi-crisis esasinawo. Aye on contract njalo nje i-renew i-contract yawo 3 months 1 year kanjalo kanjalo. So to address again ama-issues okushodelwa staff, these nurses are being absorbed into the system permanently. This is in progress because I said they were 2,100, so now we are left with 693. But this is in progress. Remember nakhona ukuthi uma usebenzela uhulumeni awuvela uvuke ekuseni nje decide ukuthi sengiyabathatha laba bathathu ngiyanika nina ngoba nikhala kakhulu. Kunezinto ezibekiwe kuthiwa wo staff establishment imali that is allocated per year yokuthi iholela abasebenzi. When you add phela ngithi kade last year ngoMarch abasebenzi be-13 mawusufaka ababili sebezoholani laba babili because imali is catered for 13 angithi niya understand. So lokho ku in progress njengoba uzoqala nje futhi unyaka omusha makwenziwe allocation i-district nama facilities kuyamotivate ukuthi sidinga more staff establishment asigcwele ingakho sibathatha in phases but kukhona esikwenzayo. Sine issue ke enkulu ye filing system ekukhalwe ngayo kakhulu lana kukhaliwe nge-filing system. Ama-clinic ethu ke were built kudala amanye kwakudonata ngizokhuluma nje nge-Waybank Clinic kwa-donate ubaba othize womdabu waseNdiya wa-donate ngomuzi wakhe. Uyabona? Umuzi sabonga ngoba yayingekho phela iclinic lapha but umuzi kababa awukaterishi for izidingo zani ze-clinic. Niyayibona leyo nto. Angithi ufika ukhale, sifike sikhale siwumphakathi, kumele silalele kube khona esikwenzayo. Kanti lokho esikwenzayo ngenxa yesimo sethu sokusebenza esingasheshisi izinto kuzophela iminyaka o5 sabandile abantu iklindli kababa ubani ayisalingani nabantu sekunama problems okunye kwako kudalwa yilokho. Kodwa konke enikhala ngako si aware of gona umnyango wezempilo is doing something about that. So lezi zindlu ke azamanye amaningi amakliniki aye nama filing system noma ama filing rooms aye mancane ayenele ngaleso sikhathi kuvula iclinic, but now they are proving ukuthi awasanele manje. Okwenzekile ke according to that ukuthi currently I district is allocate umuntu who's looking after ama filing problems and issues in facilities. I district yethu kinama facilities nkosi yama 123 is the largest in the province, one of the biggest metro in the country. So ngifisa ukuthi nazi ukuthi namhlanje manisuka la nazi ukuthi district le filing system noma kungasheshi kodwa ngelilanga kuyoshesha. Okwenzakalayo njengamanje with the assistance from HST and other partners is that kulungiswa indawo where ama files amadala ngasasebenza abantu asebathutha bahamba bashona benze njani siwa archive centrally that is in the pipeline. That is going to open the space for more new files. The space that we do not have. You go to facilities, amanyama files are in the boxes on the floor, etc., due to the lack of space. Sesige manje, HST usizile futhi uyasiza to merge the duplicate files. Konothe ama files akhe azabe u4, azabe u5 kulokuthiwa mayefika nje ifile alikho wenzelwe elisha kanjalo. So we are currently undergoing that system of merging ama files. Ake libe lodwa ifile lomuntu. Noma esenzelwa ke awu5 sivula ispace siyawa merge lawo u5 ukuze kube ne continuity in care. U80% wama facilities aka PHC athengelwe ama filing cabinets amasha that aims ukuthi utilize the space that is available in a health facility. Uma imenga kwi registration area file is lockable but lilapho umuntu ofuna ifile knows ukuthi I system ngoba kune SOP for filing litholakala phi ke leli and ithiwa I bulk filing system, meaning lilayisha more lamakhabethi alayisha more wama files so that we can try and address these issues. Yeah, all facilities in this district sesihlalile nawo phansi are compliant in terms of SOP for filing. Although there are challenges that we always experience. For example, in the staff establishment, if lithi molweni clinic njobe incane kangaka nje yayidalelwe ngalesa sikhathi because of head count and other related issues ayibe nomabhalano yedwa sezishintshile ke izinto manje sekumele simotivate ukuthi akasanele kumabhalano yedwa, we need more. That is being done progressively. Remember, if ucela imali kuhulumeni kufanele ukuthi ube nani nama facts that you are producing ukuthi if ufuna umabhalano wesibili nowesithathu yingoba abantu have increased from quarter 1 sebengaka manje we are not coping. Sengizoqeda. Kukhona ke enye inkinga esithe masibheka okay kulaba njengoba sithe PhD re-engineering baye emphakathini bayolekelela. Lana we are open to suggestions ke sisizeni nonke endlini nomphakathi ngaphandle. Abantu bayathanda ukuyosebenza baba ma mobile, baba school health team, baba outreach team, bayosebenza nama CHWs. Imoto zikahulumeni intshontshwa zonke insuku. Azintshontshwa kamnandi bakhonjwa ngamavolovolo abasebenzi. Akekho umuntu ongalisabi volovolo. Akekho namunye ba traumatized seyishintshile impilo yabo abanye abasekho normal noma ngabe ba counselishiwe but u repeated ukhonjwa ngevolovolo akekho ngayimeli into. Besicela ukuthi sinibambisane nathi imphakathi omuhle sinamaphutha sinjalo besithi siyazama siyakunina senzela ukuthi ningahlupheki kakhulu but asicela usizo ke manje nazi ingane zethu zintshontsha imoto zikahulumeni zomnyango siyisa kanjani iservice kunina sibathatha apha abantu nangu Mrs Bhayibe no Mrs Mkhize bazofakaza la ukuthi ukhona okhonjwa kanye athi ekhaya kuthiwe ngingasaphindi ngiphumele ngaphandle ngaqashwa ukuba uneswa ngaphakathi ubanike ozokwazi ukuthi asilekelele ekutheni inkingeni nazo ngaphandle ezidinga umnyango wezempilo ukuthi ibhasi lihambe liyoma lapha akagcina abafana ngokuntshontsha ibhasi lahulumeni bafuna iselfone yomuntu bafuna iwash bafuna icici bafuna iring bengifisa ukuthi nikubheke lokhu ukuthi senzani thina siwumphakathi about this sithi masihleli emhlanganweni nama team asema facilitini sikhuluma into ethi asimuzwa outreach services is not effective ngalama reasons baphakamisa izandla abantu owami uresign ngenyanga edlule abathathu bami baya counselishwa ba off sick bathinthini so sizoba nazo ke inkinga nathi sitha siveze kancane ke ukuthi ke kuko lo ngabi muhle kwethu kodwa nako ingwadle sibhekene nayo sibambiseni ke emphakathi omuhle kulena is too sensitive kukhona isolution eyafika nomnyango wezempilo ekuthiwa CCMDD la abantu belanda khona mfundisi awudingi medical aid ukulanda ka clicks awudingi into nje yethu esiyenzayo thina kahulumeni kodwa ngifisa ukucacisa ukuthi kunento eyi misunderstanding esinga abaningi abangayiqondi ethi awungeni ku CCMDD program yawa default awuzungena ke uyawa ngemzwile uthi asibekezele uyazi ukungabekezeli kwami mina ngu PhD neso omkhulu e-district angikwazi ukubekezelela umuntu ongakwazi ukubambisana ne-health system ngempilo yakhe uyabona ngithi kubasebenzi kunendlela ke yokucounselisha umuntu owenze njalo akangalwiswa kodwa akachazelwe from beginning ukuthi ubhekene no diabetes manje inkinga zakho zoba 1 2 no 3 no 4 nako kwenzeke emzimbeni wakho uthi noma ulele ekhaya uthi uyayiza inkwashe ezandleni uthi wayengitshelile unesi ukuthi izoba phezulu mangabe uphezulu ushukela wami inkwantshi manje uyabona but uma ungatsheliwe uba nomsindo ekhanda kuwena kuyelekile uCCMDD program ubekwe in place ukuze ama facilities angagcwali singayizwa lento yokuthi staff siyashoda ngoba ngilanda ka clicks ngilanda kwi pick up point ngimbonge umfundisi Mrs Mdluli ngokuthi avule izandla zakhe ngama pick up points ngikunotisile lokho and must be kune timeline ekuzomela sithole ngayi report ukuthi senikhulumile nabo sivula ama pick up points kuphi senibachazelile yini imiqathango yokuthi uma uvula i pick up point kuzoba njani kube njani so that abantu bezoyolanda enkonzweni zabo amaphilisi bezomela unompilo esontweni banikeze amaphilisi abo umuntu agoduke ngoba okwenziwa yithina umphakathi omnyama ngemnyama ngithi mina mnyama mhlambe kakhulu kunani nonke la endlini umphakathi amen umphakathi wethu uyaganga ngomnyango wezempilo ufika umphakathi ungawalanda amaphilisi ngendlela sithi siyokwenza icampaign endaweni ethize ugcwala umphakathi sijabule umphakathi udliwa unembezo ukuthi eyibukade ngawayeka amaphilisi ake ngiqhamuke lapha uqhamuka umphakathi lapha groundini lapha ayikho iprivacy engako omunye bewalandile amaphilisi akhe phambi kwayizolo fike groundini khuluma iphutha kufanele simnikeze treatment abanye banenqwaba ze treatment that expires ekhaya ngoba bayiphuzi but bayayilanda ukuze unesi angalwi naye uyayithatha afika angayiphuzi kuyingozi kwempilweni yomphakathi lokho ngicela ukunikhuza ukuthi phumani nani nilekelele ngaphandle ukuthi kodwa ke ndoda usukhale kangaka wena uyawaphuza amaphilisi ake sitshelane iqiniso nje singalwi sisodwa usukhathazeke kangaka nje ibakuthethisile impela yazi babi laba kodwa wena uyawaphuza yena amaphilisi akho uyabona ake sikhulumeni ezinye izinto siyiface head on ukuze sizame ukuyilungisa lento ngoba umnyango wezempilo umele ukuthi asiphile awumele ukuthi asenzani asife sikhohlisa abantu uma silanda treatment singayiphuzi ngendlela ubalo esimkhohlisayo asingakwenzi ke lo so ku CCMDD ukhona kodwa kuyena wonke umuntu ovela register kunama guidelines esiwalandelayo. Uma ungakalandi nje ngendlela ungakabi stable amagazi engakasho kahle awuzukwazi uku-enrollwa, but bayakumonitor banama target ukuthi ngosuku sister no sister pe clinic uthatha uregister abantu abangaki. Muhle ku CCMDD abantu abawalandi ka clicks amaphilisi. Khona lapho ke manje kwi pick up point uPharmacy Direct gives us a weekly report that says uncollected parcels. Mphakathi sonenza njani? Mphakathi omuhle sizonenza njani? Angidlule ngokusheshsha before asukuma omunye umbhengesti. Okay. Ama outreach campaigns, the district has got a schedule for annual schedule to take services to you. Nokuthi sibabamba sebe defaultile sibalinke back to care because we care. Lokhu sikwenza nama partners ethu o HST nabo bonke TB HIV care esibonile nikhuluma ngabo la. So ke please do attend these things, nibe honest. Enye inkinga ke bathandekayo ile yama address nama telephone numbers. Uyazi sesisuke sesifuna ukuthumele u-outreach team akuhambisele ekhaya amaphilisi ngoba wena uyahluleka ukwalanda. Siyokuncenga. Address asiyitholi izungeza imoto izintshontsho abafana. Address ayaziwa. Siyifonela inamba ingeni. Hayibo number. Masibuza kwabaseduzana hayibo umama Masondo omude nje owaye ohlala bathi abantu asazana namama Masondo. Uthe umama Masondo wapi lo? So ke sizonenze njani? Bamsanani nathi ke kuzo zonke lezi zinto ukuze nathi masizama lokho esikuzamayo noma kancane kodwa sihlanganeni halfway izinto zethu bese ziyalunga. Sengivala kwayisho lo mama esontweni uyabaza umfundisi basho kanjani naba befundisi bayasho. Okay, key populations. We attended workshop ngapha eGoli. I-definition ka key population ngifisa siyi-understande kahle. Ihlanganise amadoda alala namanye amadoda. Ama-sex workers, people using drugs, trans people, abantwana below the age of 15, kanye nama bantu besifazane that are pregnant. Bonke labantu ba ama key population. What I learned as a take-home message from that workshop is that all our facilities should be key population friendly so that sizonqoba i-struggles asa HIV, ama STIs kanye ne-TB. However, senzani ke thina ngaloko. Sine facility eyodwa thina lapha ya evuliwe ngase Eddington ngoba i-recommendation eyodwa ithe asibeke nanomi 2. Lalikhulu boyitheku ngisuke eMsunduzi bridge ngiye Eddington ngiyofuna leli clinic. So wonke ama clinic si promoter ukuthi awabe njani awabe friendly to key populations. Angiyazi inkinga iqhamuka kuphi in terms of this because kusukuthi fanele silungise isystem yaku registration size nama vital signs. Akekho umuntu okufanele akhulume nami ngenye indlela zonke lezi indawo ngize ngiyofika consulting room where there is a privacy between mina no sister engizomtshela ngempilo yami abese yayibheka. Kukhona ngikuzwile sikusho la sangakuthandi kodwa usister kwakufanele akubuze as a history taking so that wena individually kufanele utreateke correctly. Ne understand? But indlela ke abuza ngayo. Ne understand? Indlela abuza ngayo ngoba mina nje kuthiwa ngakhula ngiwuTomboy. Uyabona? Uma sengena ke endlini uyangibona umuntu ukuthi ngiyintombazane but nginesimane esithize nje. Uyabona? Kumele abe nendlela yokuthola ihistory ngoba uma kufanele treate usexual transmitted illness owalaba abazibiza ngama females ungaphambili. Angithi kukhona usexual illnesses uthola ukuthi unezinsumpa ngaseyinqini. So manje ufika kanjani ke uma ningekho nina in a mutual understanding ukuthi hayi mina sister ngiphila kanje. Uyabona? And you should not be ashamed. Lento thina siyabantu abamnyama besingayazi asijwayele. Still abanye bethu basa judgmental and we are working on that. Angithi ngifuna mina ukukhuluma ngomphakathi waseThekwini othe noma uCovid usubulala siba yathe goma umphakathi uthi cha. Ngikhuluma ngomphakathi mina wani waseThekwini engiwaziyo engiwuthandayo engiwusebenzayo. Sesikhulume sajuluka sasebenza ubusuku nemini. Hayi gomani bafowethu gomani takwethu goma sithandwa sami ncenga ukuthi ugome. Athi umuntu cha ngizwe kuthiwa noma ngizugoma noma kunika iattitude. Kulungile konke lokho. Ngifuna ukuthi le nkulumo yethu namhlanje ngoba silwi futhi asixabene. Siphume la sibona ukuthi ikuphi la kufanele sibambe khona sizwakale thina siwumnyango soshaya u80%. Ake nize noma ino 20% simithishane halfway to make 100. But kuyo yonke into esikhulume like la endlini emanator from ama negative and bad stuff attitudes logo signothile. We have embarked as a district sa developer ushintsho lokuthi njengamanje nje I district la angithi ekhulumayo umlilo bekunomlilo ohlukene between okwenzeke ema facility nokwenza I district now siyahlangana is managers ama facilities sesiyekile emhlanganweni ukukhuluma ukuthi hey by the way anifaki uniform ayiseku by the way uniform siza nokuthi wena reporter on these indicators. What have you done from the previous poor performance and something like that? Kuyi process because ikhathi esiphila kuzona zi dynamic kuningi okushintshayo sithi sibamba lokhu kuqhamuka okusha kade silwimpi nje kaSimungumungwana neye diphtheria neka covid neyani nayani ziningi izimpi besides le esikhuluma ngayo ethinta kakhulu uHust and TB, but there is a lot of them. But we need to be seen as a district. Sibalansisa in terms of ukuthi lo mlilo uma uqhamuka subhula kanjani lo mlilo subhula kanjani before uspread like wildfire. Senzela lokho ke increase accountability ne responsibility yama facility managers abonakale ekukhathalela ukuthi kwenzakalani efacility. Why ifacility engizwe namhlanje kuthiwa iqala ngo8 yona ukhipha ama files. Umasho CHC, we are going to look into that matter again. Kuningi okushiwo ngama facilities esiwabhalile phansi. All partners have assisted us with resources. However, angithi kuthiwe ke indandane zahlula amaroma. Angithi nakuna izinto enjani. Ngakhulishiwe nami ngingazi kwamaroma kanti ngogcina ngiyilona. As improve ngalokho ngabambisani kwethu as improve kuma mandate athunyelwe ama partners aya withdraw ayasithatha staff sawo ayabadiliza abantu asifuni kule unemployment rate esinayo ukuthi kube khona omunye umuntu olahlekelwa umsebenzi kuyenzeka ngoba thina asenzanga kahle ama partners phesheya awabona ukuthi yini kanti ayimbondela imali kulelizwe lethu. So sesehlesiwe ke staff ingakho soyizwa kakhulu iphintshe but thina njengomnyango sagxuma uhalf sathi absorbe labo kwesivale la nalapha ya but I district inkulu ningakhohlwa lokho sibonge nakubona upartner sengiyavala supervision issues lana kunento esithintile la ethi bayatshelwa abaphathi angithi kunabaphathi endlini lana uthe sengihluphile lapha ya bese ngithupha umphathi athi umphathi hayi soyibona nje le issue singibabhalela abaphathi ukuthi kushiwo kanje la endlini niphethe kanjani uma uthi umphakathi uma sekune complaint. A complaint is not a bad thing. Complaint is a mina ngifuna complain ngisasebenza kule molweni clinic ekuthiwa yenza kahle ngangiphuma uhalf ngiqhasha inhlamvu ngiyobuza engathi uyakhalaza nje ma ngicela ukuthi ungibhalele ngoba ngizoyiaddressa leyo nto kusase kuseni nestaff ukuthi bekune issue nje but wena sizakala manje bese ke ngisala mina nalabo aba consent ukuze ngenze ucomplainer ningakusaba ukwenza but engik-identify namhlanje ukuthi mase ningasayitholanga ke ijoy ungihluphile umphathi wakho uthi uzobona nje isha kanginika ijoy kwayena noma engalwanga kodwa usho nje into engabambeki ama facilities wonke ama clinic ano mother facility ulindelani Goodwins Ntuzuma for example mother facility umasho CHC kamasho khona before sifike ku CEO lama clinic aphethe uPAT manager osezingeni lo mesisibhayi kanje mesisimdloni bese kuthi ngaphezulu kwakhe ureporter directly ku CEO so lo othi uzobuya ibona into indonga zawo wonke ama clinic aseThekwini zinama telephone numbers including eka district director eka CEO eka facility manager yini ningayisebenzisi ninikiwe uphuma kanjani efacility unganikiwe medication ucushiswa ukuthi igazi lakho make kwashaya u2 angisezi ukukunika imedication hayibo ikhona into enjalo eThekwini district uhambe wena ugoduka uye ekhaya lapha e-district ama-complaints ayafika ngqo kwelami office kwelika director kwekabani sibhizi ngalawo esiwaziyo areportwayo kuthina asiwazi thina manje uCEO wanimbuzi nangu khona la dingi nokuthi uzophuma ungaphethe amaphilisi kumele uthathe inamba odongeni ufonele uCEO ngilana mina manje Goodwins naba benganginiki treatment bengikhulumela lokhu nalokho niyabona okugcina ke ekufanele siyilungise kade kugcina khona oshoyo ukuthi kade egcina lo muntu esibuye sak-identifya namhlanje ukuthi i-communication kufanele siyisebenze kuma-facilities uyazi ukukhona izinto ezinhle la enizimentionile kodwa ezoniwa ukuthi anichazeliwe kahle ukuthi kwenzakalani uyabona ukhona umntwana okhuluma indaba ye-TB la wayisho njengoba injalo i-procedure ye-TB ikonta akachazeliwe so is confused konke okwenziwayo manje kuyena ukubona ngelinye ihlo elingekho right so leyo issue ngoba si-identifyile sizoyikhuluma ukuthi ake si-improve into yokuthatha i-history from ama-clients siwaxilonge ama-clients ngeke ukuthi une-TB kumele nicele ukuthi ngithe ngiyakhwehlela hawu usekukhiphela i-antibiotic nje awusabeki nento lena nje elalelayo ukuthi ngithini ngilalele lana awusangilaleli nje ukuthi TB yona enjani lena uyabona so impilo eyakho nawe kumele ube nani nendawo oyidlalayo in terms of your care angithi mina nje udokotela wathi nginoshukela dadewethu hayi usemi WhatsApp group wathi nginoshukela angiphumanga endlini kwafanele kuma umuntu mhlambe ngoba nginalo ulwazi oluncane ngimbuza ukuthi dokotela ngimbuza into engiyaziyo ukuthi dokotela yini indaba uthi ngine TB nginoshukela ngingenasihlobo ngingenani nani wabeka phansi ipeni wabona ukuthi ngathi kuthanda ukushubashuba wabuza ukuthi emsebenzini wathi engathi umsebenzi wakho stressful kakhulu so yenye yeinkinga lezi ezidala ini i-diabetes so ngaphuma lapho ngi-right ngoba ngathi bangishayela ekhaya kwathiwa ugqokeke imask umntwana lapha eMathekwini aba-understand ekhaya ukuthi ushukela wawutheni ngoba akekho umuntu onoshukela so sinayo inkinga yokuthi thina eminyangweni wezempilo singachazi kahle umuntu simchazele from the word go ukuthi into esisolayo noma eyenzakalayo la kuwena ithi nokuthi khona uzoye ekhaya uyokwenza a conscious decision yokuthi uyazi ngiyadinga ukwadla amaphilisi ami angidingi ukuphushwa umuntu yini umphakathi omhlophe ungaphushwa wona ngokudla amaphilisi ipercentage yawo edla amaphilisi mhlawumbe ingaphezulu kwale yethu but hayi akekho umuntu othuma umuntu sonke siyayiyela emaphilisini ethu sonke sizoyisebenza ke lento nethimba engihamba nalo ukuthi kusasa ekseni kumele sibe sesiyikhulumile lento nasemihlanganweni elandelayo siyi-reinforce masiyo visit ama-facilities si-check ukuthi kuhamba kahle sengihlala phansi okay sengikhulumile ngezicelo zethu ukuthi uma ningekho satisfied khuphukani nelada izincingo zigcwele lapha ya nithumele no WhatsApp etime mayingekho kulezi number ezikhona lapha ya esiyibekile eindongeni zawo wonke ama facilities up to district director khona into ekuthiwa appointment system yeyi sikhuluma mina ke English hayi kahle ngize ngifuna i-dictionary ukuthi sichaza kanjani ukuthi asiwini ngani eThekwini ngeappointment system uthe usisi noma ubhuti okhulumile ekuqaleni wathi uthi mawumisisha usuku olodwa nje kusasa wena sekuthiwa ngo2 kukhona abakusasa ababhukiwe nje sebefelani bona ngoba bafikile ngosuku lwabo niya understand into niya understand isuka kanjani babhukiwe list yonke ukuthi hayi ke namhlanje silindele abantu abawu45 hayi ungafiki wena bangafika abawu5 abawu45 bakusasa sesibashifta kanjani wena ngoba usufikile bafikile bona ngeappointment yabo date yabo avisiza lento eappointment system cela nizame ngokusemandleni ukuthi uma uyolanda amaphilisi ungathumela noma umuntu akuhambele ngosuku lwakho ayokulandela amaphilisi ukuze uyigcine iappointment yakho ungabi nenxushunxushu nezinkinga niya understand lokho asiwini with this one bese nilanda amaphilisi ke bahlobo alandeni amaphilisi awenu silapha yasizonikeza amaphilisi noma aku-CCMDD point pick up point kuphi landana amaphilisi sibe umphakathi onjani ophilayo ngiyi-politician njalo yawo correct addresses and adherence to treatment as well. So ke ngaloko esikushoyo siwumnyango sithi ngeke siyeke ukuzama ngeke sikiyeke sinizwile namhlanje sihamba nayo lemiyalezo abadinga usizo bazoxhumana nengihamba nabo bese kuthi abasenezinkinga umuntu akabuyele efacilitini yakhe kuningi engikuzwile ukuthi ngayeka mina ukulanda lapho efacilitini especially when we came to key populations item hamba nje eclinic la hulumeni eclinic umuntu ongenzi kahle udinga ukuthi senze njani simmanage ngendlela sireportele siyakwenza sesiqalile into ekuthiwa ubani uconsequence management ngiyabonga kakhulu
ngicabanga siyabonga mama Masondo I had to give you enough time mama Masondo kwenzela ukuthi sibe nokwazi uyiva kahle lengqondo sinikeza yona not thina balapha but across this thing abanye abantu are watching it from outside South Africa and I hope moving forward all other district directors will be like you to come and tell the people what you are busy with because we are not privy to this information. And we hope, as I'm saying, you are going to work with those who are under your stewardship to encourage them to do the same in terms of conducting community imbizos as facility manager or sub-district manager to tell umphakathi about the services that you have and changes that you have so that omunye nomunye athathe that information ayisephakathi kumphakathi. But also kwizinto okhuluma ngazo you challenged us and I liked that because we need to hold each other accountable so that we can be able to improve services. Out of all the things that you spoke about, Mama, that are important is the fact that you challenged us to say akuna muntu who must leave a facility without getting the services they want. So I hope umphakathi uzivele nawo ukuthi if you are being ill-treated, we know what to do. We need to be stubborn now. When you are being ill-treated, let's not leave the facility singayithola ngento esidingayo. Kuthiwa i-numbers zikhona emabonini and all that stuff. Let's follow that. But also, Mama Masondo, the other thing that akhuluma ngayo indaba ye-levels of crime and how is a crime impacting access to healthcare services. We've got Ingukela, Ponondabo, no community Simpiwe, and all of us. I think we need to reach out to the district and the provincial commissioner of police with the department so that we can find out how best can they assist the department when it does the community outreach to protect both the providers and the users of the services. So siyabonga Mama Masondo anzokhuluma ngezinye because sekulate already and we are still driving to eThekwini. So I mean in my respect asival Mama Masondo asilwanga and singalwanga nje inhloso yethu ukuthi si-improve i-services and we appreciate your leadership and we will continue to work with you and other officials who are like-minded. Khona enye ingoma xa sivala ke ethi kancane sekusele kancane sizophumelela hayi kancane sekusele kancane sizophumelela eThekwini sekusele kancane eLimpopo sizophumelela amandla. So comrades, we have closed the meeting. Now I've got a request. These comrades have organized